workshop with our first speaker, our opening batsman, Dr. Nanda Kishore. He's a pediatric intensivist, now was at KIMS, now at Rainbow Children's Hospital, Hyderabad, and he has extensive experience with both, I think, adult, neonatal, and pediatric ECMO. Over to you, Nanda.
Okay, thank you, madam. Good evening, everyone. So it's kind of made it generic both, including all three age groups, neonatal, pediatric, and adult. But feel free to interrupt and ask any questions. So let's start with, so what I thought was, so start with a little bit of history and how it evolved, ECMO, and then look at the indications and when you actually think of going on ECMO, and the conditions where you don't offer ECMO, and a little bit about modes of ECMO, and then we'll conclude. So ECMO stands for extracorporeal membrane oxygenation. It's also called the ECLS, which is extracorporeal life support. So what it means is you're trying to provide oxygenation and hemodynamic support from outside the body. So in a way, you're providing the lung and heart function from outside the body. So that's how it works. So it's indicated when you have either lung issues or both combined cardiopulmonary failure. So if you look at the history, I mean, it's kind of started with 1930. And like, in a way, if I put it this way, ECMO is nothing but a modified version of cardiopulmonary bypass, which cardiac surgeons use it for the open heart surgery or bypass surgeries. So it's a modification of that where it can be run for, rather than a few hours in operation theater, we can do it for an ICU for days and weeks, sometimes even months. So kind of you can say how the cardiopulmonary bypass evolved, the same thing for the ECMO as well. So it started in 1930 with Dr. Gibbon developing the roller pump for extracorporeal support, where he performed ASD report in an 18-year-old girl. Then main thing came where the oxygenator was kind of started, and that's when they took in a big way in cardiopulmonary bypass. But they used to use the bubble oxygenator, which is many complications were there. And then came the silicon membrane oxygenator, which could last for longer for days and weeks, where it was possible to run the ECMO for a few days to weeks. And the first ECMO was done in 1972 in an adult road traffic accident victim with ARDS. Here's the one, was there lying here in 1972, a lot of machinery there, and this is a bubble, this is a bubble oxygenator over there here. So it was a huge machinery filling the entire room. Now if you look at it, it's come to just same size as a ventilator next to the bedside. So this was the first adult ECMO was done. But then later on, adult intensive care ECMO was not taken up in a big way until very recently. So we'll come to that in a bit, because what are the adult trials or intervention they've done not met with success. So it was not kind of given up in adult intensive care. And he's the man who actually took the ECMO and kept it going. So he's Robert Bartlett is considered the father of modern ECMO. So the major kind of milestone came in 1975 when he performed ECMO for a mechanoaspiration baby with persistent pulmonary hypertension. So the interesting story around it, a mother was an illegal immigrant to US. She crossed the border, came in, delivered in a hospital, and left the baby and went off. And this baby was struggling for life with mechanoaspiration. So the team of Dr. Bartlett team went down to the NICU with all their equipment and performed the ECMO. Because option was at that time, either you give up on the baby or try something. So that's how it started. And this was the baby, the first ECMO was done in neonates, and which came out well. And this is her 35 years later. So she's kind of a famous person in the ECMO world, where everybody quotes as the first ECMO, successful ECMO for non-cardiac patients. For respiratory reason, it was done. And I was fortunate enough to meet him in a conference. He's still going very well in US. He's not in active practice, but it's kind of inspiration to all the people who pursue ECMO. So then the similar time, adult people have done some trials which were not met with the success. It was not taken up in adult intensive care. But neonates, it's taken up in a big way, where multiple trials in neonates was but quite successful, and it kind of proved that it was saving lives. So both in US and in 1918, an extra-corporate lifesaver organization was formed called ELSO in Michigan. So this is a parent organization till date. It collects the data of all the ECMO runs worldwide. And if anybody wants to start ECMO or already have ECMO, not a member of ELSO, please do become a member of ECMO because it gives a lot of advantage of where you can put your ECMO register data and you can compare with your own area or rest of the world as well. So all these trials until war were only like a case-based and individual center dependent. First randomized control trial was done in neonates in 1992-95 in UK, where it proven beyond doubt that ECMO was useful in neonates. So then ECMO became the standard of care for neonatal mechanism aspiration PPHN. But adults was still, they didn't have any success until that time. So it was not, so its only indication for ECMO at that point of the time was neonatal respiratory failure. And it was extended to pediatrics where the pediatric had respiratory infections and there's no trial was done in pediatrics, but retrospective data was shown that it was quite useful in pediatrics as well. So until 2009, it's ECMO means is only for the neonatal intensive care unit or neonatal respiratory failure. That's when the things have changed in 2009. And if people remember, that's when the swine flu pandemic also came. That's when adult intensivists were stuck with the patients with ARDS where they could not ventilate and go any further. Similar at that time, CSER trial was published. That was a randomized controlled trial done in adult ARDS, comparing the ECMO with conventional management. And that proven that ECMO was useful in compared to the conventional mode of treatment. And around that similar time also, ECMO technology has changed quite a bit where the oxygenators have become hollow fiber oxygenator, where they become very low resistant circuits, and they were able to run for longer and longer without much complications. So all this put together, ECMO was taken up in adult intensive care in a big way. And if you look at it, actually the data, the adult numbers outnumber the pediatric numbers now. So this is an adult randomized control trial where they, this is looking at the ECMO arm, this is looking at the conventional arm. And if you look at it, 63% survived without disability compared to the 47% survived in the conventional mode of treatment. So this kind of established that ECMO was useful in adult ARDS as well. So the ECMO technology has changed, has become more miniaturized. So coming to Indian scenario, so it was started, I remember, kind of from UK, where I trained. My mentor, Dr. Sunil Pubani, used to come to UK, to India for the critical care conferences and give lectures. This was in kind of 2009 and 10, where it was not taken up that easily, and people thought ECMO is quite costly affair, and there are a lot more issues pending which we need to sort out rather than concentrating on a very hi-fi treatment. And then at similar time, ECMO was started by in India, Dr. Venkat Goel and Dr. Pranay Voja at Mumbai Riddhivinayak Hospital, where they tried initially with the cardiac patients and then followed with the respiratory patients, and where they got the success. And they were joined by Dr. Sunil Pubani, and ECMO Society of India was formed. And we became the part of the ELSO chapter in 2013, and first meeting was held in Hyderabad. Dr. Sunil is the founding chairman of SWAC ELSO. SWAC ELSO stands for South and West Asia chapter of ELSO, which includes India and Southwest Asia, and part of Africa as well now. So it's become a quite active chapter right now. And if people from Chennai, there's a SWAC ELSO conference happening next year in India in Chennai. So if you're interested, then please do attend get opportunity to meet a lot of experts from all over the world in ECMO world. So I do consider these three people, Dr. Venkat Goel, Dr. Pranay Voja, and Dr. Sunil Pubani, Trimurti of ECMO for as far as India is concerned. And they're still very active and going. So yeah, coming to ECMO per se, so one has to remember that ECMO does not cure the primary disease. Rather, it gives rest to the diseased organs where the diseased organ can recover sooner and then keep the patient alive until that time. So suppose you have a bad ARDS with lung injury, rather than bombarding with high pressure ventilation, you support them with oxygenate from outside the body, where you do not put on high pressure ventilation, lung can recover soon, and until that time support the patient on ECMO and then go back to ventilation when the lung recovers. So you have to remember that it is a supportive model of treatment, and for it to be working, primary pathology has to be reversible. So whenever you're considering ECMO, question yourself, is this primary pathology reversible or not? If it's not reversible, you really need to think what is the destination therapy you're going to offer. If you do not have any destination therapy, do not offer ECMO. Because it's very easy to go on ECMO, then you get stuck. Then what, you don't know what to do. And in India, it's a very financial also issue. You'll be stuck whether you cannot go forward, you cannot come backward either. So it is like a bridge to some destination. The destination majority of the times we expect it to be recovery. Sometimes if the bad lung injury or a bad heart where it's not recovered, then you need to have a plan about transplant too. So you need to have that discussion with the family, how long you're going to put the patient on ECMO. And then end of it, if it doesn't recover, what is the plan? Sometimes we may not have that information in situations like where the patient presents in a cardiopulmonary arrest, you're doing a CPR, and then you go on ECMO. At that point of the time, we may not have enough information to decide whether the pathology is reversible or not. You can still go on ECMO, but you need to have that discussion with the family that there's an element of uncertainty. We don't know the etiology of primary pathology, and then that we can only work out when the patient is stabilized. So if the pathology becomes obvious that it's not a reversible thing, we may go into withdraw the case. So that discussion has to be there with the family. So the point here I'm making is you need to have some exit plan and have a discussion with the family. Because many times we go on ECMO, I mean, first few days is okay, 3-4 weeks, 5-6 weeks, then patient is exhausted, and you're getting a repeated hospital-acquired infections, patient is not getting better, not getting worse either. Then you're kind of in a dilemma what to do. So don't be in that situation because you put a lot of hard work there and you shouldn't get a blame that you're just exploiting the family for the money's sake. That can happen when they exhausted all the resources. Right, so coming to indications of ECMO, as we discussed, is going to provide either a oxygenation support or a cardiac support. So depending on what your pathology, you think about what kind of ECMO you need. So coming to respiratory indications, common indications are ARDS of any etiology. Either it could be viral, bacterial, or aspiration, or chemical, whatever it is. Any lung injury where you're not able to support the patient with the conventional modes of treatment. One has to exhaust the conventional modes of treatment. The reason is ECMO is a quite invasive mode of treatment and then complications associated with it. So you need to really weigh the recent benefits before offering ECMO. So that's the reason we would say exhaust all your conventional modes of treatment before offering ECMO. Other conditions would be status asthmaticus, where you've tried everything, the patient is on ventilator, still gas exchange is not good, then you think of going on ECMO. Foreign body aspiration, where you're obstructing the main airways or one of the main airways, or you have a airway obstruction, a mediastinal lymphadenopathy, something like a lymphoma, mediastinal lymphopathy, compressing on the airways. Then you need to go on ECMO, support the patient, and then do other means to treat this lymphadenopathy. Or sometimes it could be rheumatological conditions like a vasculitis or alveolar hemorrhage, or a trauma with lung contusion. We also use ECMO in pre and post lung transplant scenarios also. And the mechanism aspiration, diaphragmatic hernia are the two conditions which are mainly in the neonates. So when you actually think of going on ECMO, there's various criteria there. In adult intensive care people, they use usually the PF ratio, and pediatricians more well versed with oxygenation index. It's the same thing of mentioning differently. So if you have a bad lungs with the PF ratio less than 100, I think one should think about it ECMO. If it's less than 50, we should go on ECMO. If it's less than 80, if it's not getting better even after 6 hours, then one should go on ECMO. Mentioning similar thing another way, with pediatricians, we use oxygenation index, which takes into account your ventilatory parameters also, in addition to your PF ratio. So that kind of gives a composite indicator how much support you're needing to maintain that level of oxygenation. And ECMO is indicated if oxygen index is more than 40, but one should really think about it if it's more than 25. because more than 25, we should have a discussion with the family. If you're not an ECMO center, please discuss with the nearest ECMO center and see whether the patient can be shifted out. Because when the oxygen index reaches to 40, it becomes even difficult to transfer at that point of the time to the patient at ECMO center. And some of the other indications are you've tried everything else on HFO, nitric oxide, or either acidosis is there, CO2 is not getting clear despite all your measures, we should think of going on ECMO. Sometimes it could be a clinical decision at bedside combined with these things and to see how fast the patient is deteriorating. Coming to cardiac indications are cardiogenic shock of any etiology. The common indications in pediatrics is usually the myocarditis or a cardiomyopathy, or is usually post-cardiac surgery or a pre-cardiac surgery stabilization. You have intractable arrhythmias, or could be part of multi-organ failure and sepsis, all those things. In adults, if you come to pulmonary embolism as well, you can think about it, postpartum cardiomyopathy, or doc intoxications. I think cell-phos poisoning is quite frequent in North India, where it is a cardiotoxic issue. So again, when do you actually go on ECMO in a cardiac patient is, again, it has to be a bedside clinical decision, keeping these things in mind. Hypertension, even on 2 inotropes, when you've kind of given maximum dose of inotropes and still not getting better. A low cardiac output with evidence of end organ malperfusion like oliguria or increasing lactate or low mixed venous saturations. The one point you need to think about is don't wait for it going to renal shutdown or a liver hit. Then that becomes the single organ failure becoming into multi-organ failure, and it's very difficult to support the patient on multi-organ failure with ECMO. And outcomes also won't be that great. So one need to be really careful timing of ECMO, because success depends a lot of the times how soon you go on ECMO. You don't want to go too soon when it's not indicated, but you don't want to delay too long where the patient is going into the multi-organ failure. So one need to be really careful, watch the patient very closely, and look for the evidence of any organ injury, and then think of ECMO at least opportunity. Other indication going on ECMO is extracorporeal CPR, where the patient comes in cardiac arrest. You've done the CPR, heart is circulation is back, but heart function is too weak to sustain the life. Or so for it to be successful, this has to be usually in-hospital cardiac arrest or witness cardiac arrest, where the chest compression have started immediately and good quality CPR is going on. And pediatrics, sometimes usually cardiac arrest is consequent to the hypoxemia. In those situations, eCPR may not be a right option. But if you have a primary cardiac problem and the cardiac arrest, and then eCPR could be a good option. So some of the contraindications are, as we discussed, for it to be successful ECMO, pathology has to be reversible. If the pathology is not reversible, then you need to really think if ECMO is indicated or not. And if somebody has an irreversible brain damage, then obviously you don't want a patient in persistent vegetative status and alive. Or a severe neurological compromise where the patient has intracranial injury or with a mass effect. Or neonates with more than grade 3 or grade 4 intraventricular hemorrhage. Because we would need anticoagulation on ECMO, and these things are going to get worse with heparin. And this aortic dissection, aortic insufficiency, mainly for the adult patients where ECMO cannot be used, because whatever ECMO you're using is going to increase the afterload to the heart. And if you have aortic insufficiency, aortic dissection, where we're going to pump the blood into the aorta, but that's going to get worse, so we cannot go on ECMO. Or somebody has incurable malignancy or lethal chromosomal abnormalities like trisomy 13 or 18. Down syndrome is not a contraindication for ECMO. Down syndrome children offered full treatment if the pathology is reversible. And again, for the extreme premature babies, we don't put them on ECMO for the obvious reasons of risk of intraventricular hemorrhage. There are certain relative contraindications are there where one need to really give a second thought. What is the component of reversibility here? And what are our expectations here? Some of these are like if you have a pre-ECMO mechanical ventilation more than 14 days. When I say 14 days mechanical ventilation, is what I meant is high pressure ventilation. So I don't want the patient to be bombarded with high pressure ventilation where the lungs gets irreversible damage, then go on ECMO, and then patient gets stuck on ECMO, not getting better, not getting worse either. You don't want to be in that situation, so you need to really think about that. If you have a transplant option, maybe you can consider that. If you have a decent neurosurgical procedure or intracranial hemorrhage in the last few days, so you need to think about what is the anticoagulation strategy. Sometimes you can go on ECMO without anticoagulation, and it's a very selective set of patients, taking some precautions, but that has to be elective decision and with a multidisciplinary team decision. Somebody has a pre-existing chronic illness, poor long-term prognosis, need to think about. Again, similarly, advanced age, again, it's a kind of relative contraindication. What are the comorbidities are there? Is the primary pathology reversible or not? Somebody is a healthy, more than 65-year-old, single organ failure. I don't see any reason not to offer, but somebody's a lot of comorbidities are there in addition to the either primary cardiac problem or lung problem. They need to be really realistic about the expectations. And again, don't offer ECMO if you do not have a destination therapy. Premature babies, sometimes we do take up to 34 weeks and up to 2 kilos. It's not done in India. The sole reason being we don't have enough smaller size cannulas for those babies and expertise to cannulate those babies. But in a good centers, they've been offered ECMO, and even premature babies up to 34 weeks, not less than 34 weeks. So coming to per se ECMO is, as I said, so what we're doing here is we need a 2 access points where you drain the deoxygenated blood from the venous side of circulation with the help of a pump, and you pump into the oxygenator where the gas exchange happens. That means your oxygen is taken up and carbon dioxide is removed. That oxygenated bright blood is given back into the patient circulation. So depending on the where this access point, ECMO can be primarily divided into veno-venous mode of ECMO or a veno-arterial mode of ECMO. What it means is drainage point is always on the venous side of circulation because we want the deoxygenated blood to come out of the body and get oxygenated. And then when you're giving it back into the venous side of circulation, it's called veno-venous mode of ECMO. Then that's primarily used for the respiratory indication where only lung support is needed. So here what you're doing is you're taking the deoxygenated blood from the venous side of circulation, giving back into the venous side of circulation again at a different point. So that oxygenated blood will go back to the native heart and gets pumped back into the rest of the body. So there you're not bypassing the heart, it's only supporting the lung function. But if you have written cannula or oxygenated blood, if you give it back into the arterial side of the circulation, then you're supporting the heart as well. So we'll go through that in a bit. So basically that's what 2 access lines are there, and depending on the primary pathology, primary cardiac failure, you think of veno-arterial mode of ECMO. If you have a primary respiratory failure, you think of veno-venous mode of ECMO. We'll go to that in a bit. So again, drainage point is always from the venous side of circulation. There's different points of the where you can drain the blood, either depending on which side you're going to use it, either femoral vein, right atrium, and return site. If you take a femoral vein, this is the common kind of veno-venous mode of ECMO, where you drain from the femoral vein, give it back into the internal jugular vein. So this is how it works. This is a very common mode of ECMO being used in adult ARDS or even pediatric also. So you drain the blood, put a drainage cannula from femoral vein into the IVC, where you drain the deoxygenated blood, then run through the ECMO machine, and the oxygenated blood is given back into the internal jugular into the SVC. So basically, in a way, one below the heart, one above the heart. You drain the blood deoxygenated from below the heart, give the oxygenated blood into the above the heart, where it goes into the heart and gets pumped into the rest of the body. So that is a typical 2 cannula technique. So you can do the reverse also, where you drain the deoxygenated blood from the superior vena cava, give the oxygenated blood in femoral vein. This is not generally indicated. This is only indicated in children who are not walking, because children who are not walking, the femoral vessels are not well developed. So we can't accommodate a big enough cannula in those children. So in those children, we can try if you're desperate, but generally it's not advisable. But in desperate situations, we can try. Another thing is you can try both femorals. So one femoral draining, other femoral giving it. But the problem here is you need to make sure that cannulas are at different lengths so that you can avoid the recirculation. Otherwise, whatever the oxygenated blood you're giving here gets sucked back into the circuits and very little going into the patient. So you need to be careful of that. This is usually generally not indicated. Again, it's indicated if you're not able to cannulate the neck vessels for any reason. In those situations, you can try it. Other common mode of ECMO, which is done in Western world, is the double lumen cannula, where the single cannula with 2 tubes, where it's cannulated from the SVC into the heart. So it's like similar to double dialysis catheters. Technology is slightly different, but it works very well if you can position it properly. But these cannulas are right now not available in India. Maybe if they becomes available and it becomes easy for us to do, venous mode ECMO. Advantage with this is you can spare the femoral vessels and problems associated with it, and you can mobilize the patient as well a bit better. Come to veno-arterial mode of ECMO. Again, you can do at the peripheral or central. Peripheral, again, the drainage is always from the venous side of circulation. Return point, either you can give it to the femoral artery, axillary, subclavian, or a carotid artery. Another mode is the central ECMO, where post cardiac surgery, you do it. Drainage point, usually right atrium, and give it back directly into the aorta. So what we're doing is that this is a typical configuration of veno-arterial mode of ECMO, peripheral veno-arterial mode of ECMO, where you put a drainage canal in the femoral vein into the IVC, and you return into the femoral artery here. So this is how we do it. So this is a 11-year-old girl with myocarditis, with the drainage cannula is there in the femoral vein and the return cannula here. When you're putting such a big cannula into the return femoral artery, you were worried about the distal perfusion. So you put another smaller cannula here for the distal perfusion to maintain. So this is another veno-arterial mode of ECMO in children who are not walking yet, less than 12 to 15 kilos, where you cannot cannulate for the femoral vessels for this, just because they're not good enough size. So in those situations, you drainage from the right atrium, but return into the common carotid into the aorta. That's how we do it. This is not indicated in adults because obvious reasons of cerebrovascular accident if you're going to cannulate the carotid artery. But in children, they don't have atherosclerosis and circulation from mother carotid is good enough to supply through the circular villus, so we can do that. But that's only in children less than 12 to 15 kilos. So this is a baby, a newborn with aspiration.
Nanda, your audio.
Are you not able to hear me, madam?
Now I can. Now we can.
Okay, sorry. Yeah. So this is a newborn baby with mechanism aspiration where we cannulated the internal jugular into the right atrium. This is a drainage cannula. And then you have a return cannula here, smaller one from the common carotid into the aorta. And this is how it looks here. This is a central ECMO. Usually it is offered post-cardiac surgery. The problems with it is open chest, obviously, with risk of infection and a lot of bleeding with open wound. So usually it's done in a cardiac centers where the cardiothoracic surgeon is backup available all the time. So some other indications of ECMO or extensions of ECMO, you can say, is extracorporeal CO2 removal, where this cannulated femoral artery, there's no pump here. The patient's native heart pumping in the blood, it goes through the oxygenator where the CO2 is removed and a little bit of oxygen is given because flow is not that much here. And the CO2 removal is given back into the femoral vein. This is usually used in adults with where you're doing lung protective ventilation, but CO2 is not able to clear. So in those scenarios, we can think about it. And the other Indian jugaad was done for this version was to use the CRRT mission with the pediatric oxygenator. I think Team Kolkata, Dr. Arpan and Dr. Deepanjan, they are doing it. I think if you get opportunity, you can go through that. So they use the CRRT mission with the pediatric oxygenator to use as an extracorporeal CO2 removal. Because for CO2 removal, we don't need high flows. So other indications, future indications are in transplant scenarios. This is like you maintain the perfusion, so minimize the cold ischemic time or avoid cold ischemic time for these organs. So you sustain their metabolism with the extracorporeal circuit. So these are kind of indications in a transplant scenarios like this. So with that, I'll conclude. So just conclude, consider ECMO when you have a refractory heart and lung failure where you've exhausted all your conventional modes of treatment and you think primary pathology is reversible, then offer ECMO. When you're offering it, offer early before end organ damage happens. There's no point in having multi-organ dysfunction on ECMO because outcomes are really bad with multi-organ failure. And think of veno-venous mode of ECMO if you have a respiratory failure or veno-arterial mode of ECMO if you need a cardiac support. So one need to have a discussion that with the family and assemble your team and go ahead. And then hybrid modes, I think that's probably not needed right now. We can discuss when we meet up in person if somebody is interested. So with that, I'll conclude. Thank you very much for listening. Happy to take any questions.
Thank you, Nanda. So feel free to ask questions to Nanda. So Nanda brought out very beautifully that any reversible, the contraindications for ECMO are shrinking now. So if you feel the patient, be it adult, pediatric or neonate, can have a good quality of life and survival, please offer. And bleeding, low platelets is not a contraindication for ECMO. You can use high flows and continue ECMO and save lives. Even head trauma with little bleed is not a contraindication for ECMO. And I know my pediatric colleagues, even in Bangalore and all, he's going to be a faculty as well. Dr. Shiv, there was a child with head trauma, with little bleed, lung contusion, ARDS, offered ECMO, and the child survived. So immune compromised state, HSCT, trauma is no longer a contraindication. There is a question, Nanda.
Yes,
Nova lung would increase risk
the thromboembolism due to low flows. Yes, it would, but then you need to maintain the anticoagulation. Probably need a little higher ACTs than conventional ECMO.
There was a question, double lumen cannula does it also cause recirculation?
Yes, I didn't go in detail because the time is short. It can cause, but the way, if I can go back, maybe, the way it works is, okay, I probably need to share my, is it visible, madam, my screen?
No, not yet. No.
Not yet.
I think Nanda, she's no longer co-host, so you won't be able to share.
Oh, fine. No, so basically what it is, madam, you can, there is a risk of recirculation, but you need to really make sure that you position a cannula in such a way that if you look at the cannula, there's a two drainage holes are there. One at the bottom end, one is the top end. So bottom end has to be in IVC, top end has to be in SVC. In the middle, you have a return port where that is in the right atrium, approximating the tricuspid valve. So that has to be positioned correctly under echo guidance or cath lab guidance. So one need to be really positioned that, otherwise you'll get a recirculation.
Sir, I have made
now.
Yes. If you want to share now, you can share your screen.
You want to share? Nanda, do you want to show anything?
There was also another question in between, ma'am. By the meantime, if you want to take it, Dr. Nirav had asked to explain the PF ratio.
Like less than 100 is a severe ARDS. So one need to really think about it. Less than 100, then whether the patient is, how he's going to progress, then you need to think about it, whether you would need ECMO or not. Then again, like the one issue I have with PF ratio is it doesn't mention how much ventilator support you're needing to get that PF ratio. So that's why
yeah. So it is not just one criteria, it is the rapidity with which the patient is, deteriorating. So you don't be fixated by one number. And it could be we have seen patients who don't have a very high oxygenation index requiring high PEEP, viral pneumonias. So the PEEP may be 8, but they have profound diffusion, they have profound hypoxemia and vice versa. So it's not only the high pressures, it is also the oxygen, the hypoxemia that you should factor in. In some situations like bronchial asthma, bronchiolitis in small children, it is the PCO2. So your ventilation index. So there won't be much hypoxemia, but if you have profound respiratory acidosis with a high PCO2, so that you can offer ECMO for 2 to 3 days. That is much shorter than for ARDS. So pediatricians have even put status asthmaticus on ECMO and bronchiolitis. Of course, the other tracheal, mediastinal thing and all other indications you have mentioned.
You want to understand meaning of PF ratio. Okay, so PF ratio is like basically how much oxygen you're needing to maintain your PaO2. So basically, you measure the ratio between your PaO2 by how much oxygen you're giving on the ventilator. So if normal lungs are good enough, even if you're giving like 50% oxygen, your PaO2 should be at least 200 or something, then that means the lungs are of good oxygenation capacity. But your PaO2 is only like 50 or less than 50, that means your lungs are bad, then not good oxygenation is taken up. So it's kind of an indirect indicator how much lungs are working.
In pediatrics, we also use SF ratio. So if your SF ratio is also where you SATs by FiO2 ratio, if that
Yes.
is so low, then even before you get an outline, you will know that this patient is heading towards ARDS. There's a question, Nanda.
Yes,
ECMO indications in acute liver failure. Can it be combined with plexus CRRTs?
yes. Again, need to really think what is ECMO usually indicate either your primary cardiac problem or a respiratory problem. If you have a multi-organ failure where the liver is bad and your lungs are also bad, yes, we can support. But again, it's going to be a little complicated in terms of anticoagulation. And what is the likelihood of reversibility of both lung and the liver reversibility also? So one need to really consider those reversibility component, and then yes, we can offer.
So if you have respiratory failure or cardiac failure in a patient with liver failure, you would put on ECMO, and then on ECMO, you can connect the CRRT and the plex. So it's not the other way around, connecting ECMO to the CRRT. You can actually, you will know in the next 2 days how you can actually connect the CRRT or plex into the ECMO circuit. The next question by Swati, I think as we progress, you will hear more talks about complications.
Yes. I think this will be taken up in a, it is a real concern, but that I think we'll address in the next topics.
Thank you so much, Nanda.
Thank you very much, madam.
Thank you, Nanda. Now we move on to the next talk by Dr. Ravi. Dr. Ravi, you're here.
Yeah, ma'am, I am here.
You want to start sharing? Good evening.
I think somebody has to stop sharing, then only I can share.
It's already stopped sharing. You are Ravi, you are a co-host. You can.
Is it visible, ma'am?
Yeah, it's beginning to start. I mean, screen share. Yeah, visible. So happy to invite Dr. Ravi for ECMO workshop, Pedicriticon 2024. Dr. Ravi is a consultant pediatric intensivist and ECMO physician at SDM Hospital, Jaipur. I've known Ravi from the time, his interest in ECMO, and he's also done his ECMO fellowship program from the ECMO Society of India. And I urge all of you to do this one-year fellowship program under the guidance of ECMO Society of India, Dr. Pranay. They have a fantastic workshop and with online and hands-on at Mumbai, plus online teaching. It's excellent. So do join, get this fellowship because you can take it online. Over to you, Ravi.
Thank you, ma'am, for such kind words. So before starting my talk, previous person has asked regarding recirculation in double lumen cannula. Apart from the positioning which sir has correctly mentioned, the double lumen cannulas, they are also available as bicable cannulas. In case you want to omit that recirculation element, that bicable option is also available. So just to add to that question. So I start with my talk, which is on neonatal, pediatric and adult ECMO cannulation. I am mainly into pediatric and adult ECMO cannulation. We don't do neonatal cannulation. So the scope of the talk would comprise of cannulation types, sites, implantation options, cannulation size, cannulation techniques, cannula positioning, cannulation complication, and distal perfusion sheath. So before somebody cannulates, these are the common questions which comes to our mind. How much flow is required? That's a basic question based on whether it is a respiratory or cardiac ECMO. Where should I drain and where should I return? So where should that drain cannula be inserted and where the return should come? Which cannulation technique shall I use? So there are various cannulation techniques that we will cover later. So this is also another basic question. How soon, like how early? Once the indications which has been told about the previous speakers, are met. So how soon we should start cannulation? Who's the best person to cannulate? In our unit, it is by and large, because it's a pediatric ECMO, so by and large it is by a pediatric CT surgeon. But of late, venous ECMO cannulations are also being done by us and cardiac anesthesia colleagues. Next question is, what is my anticoagulation strategy? Because you are bringing the extracorporeal circulation by doing this cannulation, so it should not clot. So you have to weigh clot as well as bleeding both. So anticoagulation strategy is very important. How can a safe cannulation be carried out? Very important. In emergency ECPR conditions, most of the things are done in aseptic ways. So this question also comes to the mind. And the last thing is, how long? So these are the common questions once we think about the cannulation. Now, just like when we say about mechanical ventilation, that endotracheal intubation, unless it is done, we cannot ventilate. Similarly, cannulation is the airway of the ECMO. So, well beginning is halfway done. It's an airway of the ECMO. Accurate and appropriate size cannula has to be inserted. And once this is done, half of the work is done. The next question is the sites or the implantations for cannulation. There are basically two sites. One is peripheral, which is commonly used in day-to-day ECMO cannulation, and second is central, which is mainly done by high volume pediatric cardiac centers where they receive post cardiotomy or post CPB, unable to wean patients. So this is a picture of a central BA ECMO. You can see that large bore cannulas are seen coming out from the sternal open area. And this is probably a post-operative unable to wean or a post-cardiotomy status ECMO. This is a picture which is showing a neck cannulation. This is a cervical cannulation. This is a type of peripheral cannulation which is usually being done in infants and in the kids where the femoral vessels are not well developed. So here you can see the darker side is the venous cannula, which is arising from interjugular vein, and the oxygenated blood is being returned from the ECMO circuit back to the patient, and it is inserted into the internal carotid. So this is one of the form of peripheral ECMO cannulation, which is being done for infants and small pediatric subsets. So the central ECMO and peripheral. The central is it is also called as transthoracic approach, where you are connecting right atrium to the ECMO circuit and the return is coming to the ascending aorta. And the peripheral is also called as the extrathoracic cannulation or ECMO. In the peripheral cannulations, the commonly used sites are in the neck, carotid, and IJV, as I have shown you. Femoral, which is frequently done in the more than 5 years, more than 15 kgs, and in the adults. Neck and femoral combination, which is the most commonly used VV configuration, and rarely axillary. So transthoracic, as I have told, that if we are not able to do the extrathoracic, then transthoracic approach is done. And particularly the subsets are the post-cardiac surgery. A special scenario is the septic shock, where you need to have high volume or the superflows. In that scenario also, transthoracic is preferred. But the downside is they have got a lot of chances or incidence of bleeding, infection, and there is risk of dislodgement of the cannula. So this is very important. These are the various sites of cannulation pertaining to arterial and the venous side. In the arterial, aorta, common carotid, femoral artery, subclavian artery, axillary artery. So depending on the requirement, depending on the implantation sites, these are the various arterial options available. In the venous sites, the commonly used for pediatric are interjugular, right atrium, SVC, IVC, and the femoral vein. So the implantation is very important. So you have to ask the question, where is the implantation site for that particular scenario? It depends on the base of your ECMO, whether you want to central or the peripheral cannulation. So this is a dictum. The dictum is, before children starts walking, femoral vessels, they are not well developed to be suitable for ECMO cannulation and support. So so in infants, particularly when they have not started walking, the femoral vessels are not developed and they are not supported well. Hence, we prefer doing the neck cannulation or central ECMOs. So different combinations of implantation sites are possible. In the emergency setting, femoral approach is the best. If it is a more than 15 kg or more than 5-year kid, cannulation for infant and small children, as I said, that either it should be through the neck vessel or large central vessels via median sternotomy. And children more than 30 kg, it is always a femoral approach. In the central ECMO, if you need higher flows, then this is the preferred modality. For neck cannulation, it is mainly done in the emergency situations in infants and smaller kids, and it is also preferred during mechanical CPR. So when eCPR is ongoing, so without interrupting the chest compression, this can be used. Now, the disadvantage is for doing this, you need to ligate internal jugular as well as carotid. In pediatric, in the small kids, a lot of collaterals are available. The risk of ischemia is less, but there are some limitations, like in case there is incomplete circle of Willis, the risk of cerebral ischemia might increase. But having said so, but in smaller kids, this is well tolerated, and there is no clear evidence in the literature for this assumption that they would develop ischemia or hemorrhagic stroke. So these are the various implantation permutation. You can see on the left hand side, this is a veno jugular. So this is a venous peripheral, veno-venous peripheral neck, groin to neck ECMO. On the right hand side, you can see it's a central ECMO where the drain is coming from the right atrium, going to the oxygenator machine, and then it's returning back and it's going to the aorta. So this is an example of a peripheral ECMO, which is commonly done. And this is a central ECMO for post-cardiotomy or CPV patients. These are the other implantation permutation for VV ECMO. You can see this is a classical variety from femoral vein, and the return is going to the internal jugular. The second scenario, you can see this is a double lumen cannula. Okay, you can see there is a venous limb and there is an arterial limb, and it is going right to the mid of the atrium, right atrium. So this is a double lumen cannula. It is preferred for respiratory ECMOs for small kids if it is available, but the availability is an option. Like availability is a problem because it's very expensive, not easily available, and it needs to be put under C-arm. Now, the third thing is the other combination you can see here, the venous side is coming from the SVC, and the return is going to the branch of the pulmonary artery. So these are the different combinations for veno-venous ECMO. Coming to the veno-arterial ECMO, you can see this is the most commonly used for pediatric smaller kids. This is the drain is coming from the internal jugular vein, and the return is coming to the carotid. The second picture is showing the drain. The drain is coming from the femoral vein, and the return is going directly into the aorta. And the third picture is the classical central ECMO, where the drain is coming from the right atrium and the return is going to the aorta arch. So regarding Evelyn cannula, these are the double lumen cannulas, and I'll show you in the further slides that how it has to be placed. For implantation ECPR, I have already told best modality if it is a smaller kid is the neck vessels, because you need not interrupt your CPR. But if it's a bigger kid or it's adult, it has to be bifemoral. Now, regarding the type of the cannulas, there are three sets, different types of the cannula available. One is single lumen, second is double lumen, and third is the smart cannulas. We are using single lumen. We have not used double lumen, but we have seen double lumen being used in adults, but smart cannulas we are not using. You can see this. These are the single lumen SS and the return cannulas. Okay, the SS cannulas, they are longer. They have got multiple openings. But return cannulas, if you see, they are smaller, stouter, and they have got single opening. And they are all spiral. They are all wire bind so that they becomes non-collapsible. On the right hand side, you can see the double lumen cannula. You can see this is a double lumen cannula, as a previous speaker Nand Kishore sir was talking about. This is a drain point. The drain point is in the IVC, and this is the return point. The return point should be in the RA, which should face towards the tricuspid wall. So if this is being placed, this basically require a C-arm. So it requires a cath lab to insert and properly position it. This is another example. This is a bicable. So the previous talk somebody has asked regarding recirculation. So a well-positioned double lumen cannula, it eliminates the risk of recirculation. But if you see this this is a bicable cannula. There are two drain points. One is in the IVC, another point is in the SVC, and this is the return. So return is pointing towards the tricuspid wall. So this is this absolutely there is no risk of recirculation if you are using a bicable cannula, if it is positioned well. This is just to show you what is the arterial cannula look like. It is a smaller, stouter. It is it has got a spiral wire inside it so that it's become non-collapsible. So once you come to the hands-on session, we will show you and give you the feel of how these cannula looks like. This is an example of dual lumen cannula. You can see this. This is Origin company. You can see this. There are two companies available, Origin and Avalon. This is a 12 French double lumen cannula. This is the drain axis and this is the return. These are the single lumen cannulas. You can see 10 French and 14 French. In the double lumen cannula, in the smart cannula, it is a self-expandable cannula. It has got a memory to expand. The best example is transpulmonary retrograde left ventricular decompression. Though we have not used, adult colleagues, they are using the smart cannula, but it is one of the options. Regarding cannula selection, the most important points come to the mind is how do I select the cannula? What size? Which should be the venous cannula? Which should be the arterial cannula? So we should know some basics when we select the cannula. The size of the cannula, it depends on the size of the vessel. So the point of care ultrasound holds a great presence here when you want to assess for cannulation, particularly the venous cannulation. And by doing so, you also additionally eliminates the risk of clot or any anatomical variation prior to cannulation. So by pre-cannulation, you can do point of care ultrasound on the desired vessel, particularly it is used for femoral veins, where you can know by putting on the axial window, you can know what is the actual diameter in mm, and by that you can know which French cannula is required. So that is one factor. Second is the desired flow. What is the desired flow depending on whether you want to do a respiratory ECMO or you want to do a cardiac ECMO, the medical indications. Then the most important point is the flow in these cannulas. It is directly proportional to the radius and inversely proportional to the length. So wider the longer the cannula, more the resistance. The more the diameter, more is the flow. And more the length, lesser is the flow. So that should be kept in the mind. So you should choose a wide bore and optimal length cannula while selecting for cannulation. For single lumen size, this is a range available. For double lumen, 12 to 31 French is available. The 1 French is equivalent to 3 times of millimeters. So in case you are doing point of care ultrasound, if you know what is the diameter, you multiply this by 3, you get a French. This is a rule of thumb. The cannula size measured by the outer diameter. On all cannulas, the French size is written, which is equivalent to the outer diameter. So in this picture, you can see these are the, this is a double lumen, these are single lumen. These are the progressively increasing order. This is basically the size of the vein, which has been written in millimeters. If you multiply this by 3, you get the size of the, roughly the size of the cannula. Okay. So let's say this is 15 millimeters multiplied by 3. So roughly 4.5. So 5 they have taken. So this is the rule of thumb. So the size matters, bigger the better. Okay, that I have already told you. Then on these cannulas, there is a M number which is equal to the resistance. More the resistance, lesser is the flow. For venous and arterial cannulas, the desired flow is 20 millimeters pressure drop should be in the venous cannula and 100 millimeter mercury pressure drop in the arterial cannula. The venous cannula, by and large, they are larger than arterial cannula. They have got more French. They have got less resistance and more flow. On contrary, these arterial cannulas, they are smaller, but they bears the risk of hemolysis and higher resistance. So this is a picture which is showing selection. This is a ready reckoner for ECMO, choosing the cannula. Okay. So if you know the weight, okay, based on the weight, based on your cannulation site, you can know. For example, as you can know that this is also very important, circuit tubing, which determines the priming value, priming volume as well as resistance. So you can see in the smaller 1/4 tubing, this is 1/4 inch tubing for less than 10 kg. Thereafter, it becomes 3/8 size, and in bigger child, it is almost half inch size. And these are the various sites. So smaller kids, as I have mentioned previously, the cervical, which is a neck cannulation, is preferred. This is about the peripheral cannulation. In bigger kids, it is femoral. In between, you can choose neck plus femoral. And these are the various sizes of the arterial and venous cannula. Arterial cannulas are always smaller than the venous cannula. So try to fit the biggest possible. This is for choosing veno-venous ECMO, choosing the cannula. This is again a ready reckoner. You can see if you want to put a double lumen cannula in the smaller kids, 12 French is available. And in the bigger kids, the color combinations, the ranges is from 17 to 21 French. And thereafter, it is 21 to 23 French. So depending on neck or femoral, you can select the site. So this is the drain and return normogram, which is available in Arena, Bangalore. So they follow this. This is available from Biomedicus. And you can see this, and depending on your requirement, you can select it. And it also additionally talks about the connector. So in VV ECMO, I've already told it's the double lumen cannula, the jugular vein. In single lumen, it is a femoral vein, jugular vein, which is the commonly followed thing. And less than 10 kg, it is either a veno arterial for either respiratory or double lumen, unless you have a dual lumen cannula. So smaller kids, by and large, drain is in the right IJV and return is carotid artery. This is by and large. Bigger kids, the drain is in the femoral vein and the return is in the femoral artery. Next is the cannulation techniques. So there are 3 techniques. Seldinger techniques, which is the percutaneous technique as you do for your central lines. It is commonly followed in child and adolescent. Semi-Seldinger, which is a semi-open technique, which is mainly used for neck cannulation, dual lumen cannula, where surgeon or intensivist, they open the landmark and then they do the Seldinger. And the open technique is commonly followed for the smaller kids or in the ECPR scenario where the vessels, they are exposed and they are directly cannulated under vision. So what are the cannulation techniques? So what is a prerequisite? You have taken the detailed consent. You have to explain the family, being an intensivist, what exactly you are going to do by inserting these cannulas. Blood product should be ready. Proper positioning should be there. Patient should be completely sedated, because of when you're putting these venous cannulas, there is risk of ear embolism. So the patient should be completely sedated and your heparin should be ready. The heparin dose is 50 to 100 units per kg, maximum 5,000 units. This has to be kept ready and it has to be given in Seldinger technique once the guide wire is in place. In open technique, once you have got your landmark, which you are about to dissect, like arterial or venous, that time you should tell your assistant to give a stat dose of heparin. So the first technique is the open technique. It is generally followed for the neonate and small kid. And I've told the advantage is everything is under visualization, but you need to do a ligation. Small kids, they tolerate well and they have generous collaterals. But the problem is the jugular ligation, which is more dangerous than carotid, and it can lead to cerebral ischemia. However, studies don't support it. Like there is no hard evidence that it does happens. And second is the semi-open technique, which is followed in pediatric age group, particularly for jugular vein cannulation to avoid the jugular ligation. There is a direct access size of the vessel. No vessel ligation is done. Vessel remains patent post decannulation. The risk of cannula kinking at vessel size is reduced because it is done under visualization. The third, which is most commonly done by the adult colleagues, is a Seldinger technique. It is used for more than 10 kg in the bigger kids. There is no ligation and it reduces the bleeding complication. It is done bedside. There is no need of surgeon. Our cardiac anesthesia or intensivist colleagues, they can do it very well. The risk of vessel disruption, unlike the open technique, is not there. It can be USG guided or fluoroscopy guided. You can see the guide wire and the tip positioning, and USG localization and size and thrombus can be estimated with this. So coming to the steps of neck cannulation, we will show you in the hands-on, but these are just a gross. This will give you a gross idea of how it is being done. So this is an open procedure. First, you have to go to your landmark, which is the near sternocleidomastoid, the triangle. After you have done positioning, exposure of that area, okay, medial to sternocleidomastoid, where you are trying to figure out carotid sheath. Once carotid sheath is visible, the next step is carotid artery, common carotid artery and IJV. So you have to do looping. Once looping has been done, this is the arterial cannula. So arterial cannula, the length which should enter inside is around 2 to 3 centimeters. It should not go beyond. And venous cannula should go around 5 to 6 centimeters into the right atrium. So this is carotid arteriotomy. So there is an incision after you have put ligatures. You're putting an incision over the common carotid artery, and this is the arterial cannulation done, and then you need to secure the cannula. You can see here, and in securing there is a once arterial cannula has been secured, venous cannula positioning has to be done in similar manner. Jugular venotomy done, venous line is secured, and after that, once the clamps are open, it should be airtight. It should be aseptic, airtight, and you have to remove if any air is left behind, and you have to trace back to the machine. After that, you need to secure the venous and the arterial cannula to the skin. And the last most important step is the positioning. So you need to do an X-ray, and you need to see where is the tip of the arterial and the venous cannula vein. So this is the tip of the arterial cannula. It has crossed carotid artery. It has gone to the aortic arch. And this is the venous side. It has gone into the right atrium. So double lumen venous cannula, this is done by Seldinger technique. It is available with a kit with the sets of dilators. This is what it will do. This is the venous end and this is the return end. The steps are, you need to open the same triangular space medial to sternocleidomastoid, find out internal jugular by limited dissection, and then you need to insert this dual lumen cannula by Seldinger technique. So this is insertion of cannula, then putting the guide wire, then after that dilatation and putting the double lumen cannula, and then fixation. And thereafter, this is a position confirmation on chest X-ray, which is the tip. You can see the tip is here and it has reached to the mid atrium, and these are the holes for drain and return. So cannula positioning, there are various options. One is the X-ray, which is the conventional modality. Then transthoracic echo, transesophageal echo, which for bigger kids we are doing in our unit. Vascular Doppler, venous, it should go to the right atrium side. Femoral vein, usually to the hepatic IVC, which is non-collapsible. Arterial carotid, which is the beginning of ascending aorta. Femoral iliac, descending aorta below renal artery. So these are the various positions. Now, while putting this, there are some adverse effect. Carotid artery issue in smaller kids. the advantage is it provides good perfusion to all branches of aortic arch and distal aorta, so it decreases hypoxemia to the arch branches. But the downside is it increases the afterload, it increases the aortic pressure, it increases the afterload to left ventricle. For VA ECMO, for femoral return issues are there. Advantage is it gives a good distal perfusion, but it fails to perfuse the aortic arch. And sometimes we see that north-south syndrome when the native cardiac circulation is good and the lungs are bad. Native circulation is good, and in presence of pulmonary dysfunction, this north-south syndrome is seen, which is identified by hypoxemia in upper limb, and the saturation of right upper limb is less compared to lower limb. And you can use NIRS, and the treatment is to put an additional jugular vein for a return. So for femoral artery return, this is a femoral distal perfusion sheath is mandatory. If you are doing a bifemoral approach, it prevents the distal ischemia, and it is done only for femoral VA cannulation. The flow should be maintained at around 150 ml per hour to the ipsilateral limb to maintain the perfusion. It can be done by percutaneous or direct cut down technique. And in case you are not able to find the superficial femoral artery, the other option is to go and do the retrograde dorsalis pedis on the posterior tibial artery. This is the distal perfusion sheath. You can see this is the return cannula, and this is the distal perfusion sheath. It is getting a feeder from the return cannula, and it is going antegrade into the ipsilateral femoral vessel. So these are the various pictures which is showing the distal antegrade perfusion. Now, cannulation problem during puncture, bleeding can happen, transfixation of artery, and it can enter the vein, guide wire kinking can happen. These are the common things also encountered in central line fixation. Misplaced guide wire, venous division in the small kids is seen, and the spasm. So the best person should the best person in the house should do that. So during cannulation, the vascular injury, bleeding, arrhythmias, intrathoracic vein perforation, these are the common complications seen. So this is a limb ischemia, which is seen in case of some thromboembolus or some clots, despite distal perfusion sheath or the inadequate size. So what should be monitored during cannulation? During cannulation, the blood product should be ready. The guide wire can cause arrhythmias. There is a risk of venous air embolism, so patient should be sedated, paralyzed. Now, I've already talked about the cannulation. This is one beautiful video. You can copy the link, or you can take the snap of this link, which shows, which talks about Indian scenario, USG guided vein estimation, the size of the cannulas, and then the characteristics of cannulas. And this is being taken from MGM ECMO conference 2021. Now, this is just to share an example. The 5-year-old kid, weight of 21 kg, case of viral myocarditis. The child had LV dysfunction, 20% despite maximum medical treatment. Lactates were rising, SCVO2 was less than 60, anthropic score was more than 20. So a bifemoral VA ECMO bedside approach was preferred, and the tubing used was 1/4 inch tubing. Cannulation was done by semi-Seldinger technique by CTV surgeon. Drain cannula was put on the right femoral vein. The cannula size was 18 French. Cannula position was checked by transthoracic echo. The return cannula, left femoral artery, the cannula size was 12 French, and the left femoral additional antegrade distal perfusion sheath was put, size of 5 French. Just to give an example. Thank you very much. Any questions? So just to talk about the role of intensivist during cannulation. It starts pre-cannulation. It is during cannulation, it is post-cannulation for positioning. So everywhere, at every point, the role of intensivist is there. Thank you very much.
Thank you, Ravi. Any questions? I think there are a few questions. Won't supplying oxygenated blood into femoral artery in that anyway? Kushbu has asked, explain pressure drop. Is it with the body's blood flow?
Pressure drop. Pressure drop is a characteristic of the venous and the arterial cannula. So each ideally, this is ideal scenario, like for venous and arterial, these are the specification made from the manufacturer. So it gives you the fair, like this is the acceptable pressure drop for each cannula.
How would an additional jugular vein help in perfusion, sir?
Additional jugular vein, so actually, once we talk about veno-arterial ECMO, you see that in veno-arterial ECMO, when it is done through the bifemoral approach, the return is going to the lower limbs and it reaches to the descending aorta. So below renal. So there is a mixing cloud. Mixing cloud means the oxygenated return blood is going uphill, but it does not give oxygenation to the arch. In case when the cardiac, the ejection improves and there is a additional ARDS, the native cardiac output also fights with this ECMO flow. So the clouding, the mixing or the clouding level, it goes down, leading to the hypoxemia in the arches of the arch of the aorta. So the subclavian, the brain, the carotid, all this gets a lesser oxygenated blood. To combat this, the jugular vein is an additional drain which is going to the right side, and it is providing extra oxygenation to the arch. So there comes the role of this jugular vein cannulation extra.
So for all, very important step is actually cannulation. Now, Randa has said indications. If you don't choose your cannulae right, you will actually burn your fingers. You'll never be able to get the patient off ECMO, because the key for heart and lung support is the flows. And when you get good flows, you will have good saturations, you will have good blood pressure. So we have burnt our fingers when we, in a haste, we just put whatever cannulae available in the femoral and return into the jugular. What happened is we were not able to get good flows from the femoral cannulae. And we ended up putting 2 femoral cannulae in these small children, because otherwise it kept, the machine kept pulling, there were not enough flows, and we kept giving fluids and the patient got bloated. So it defeated the very purpose of putting the patient on ECMO, because the saturations actually got worse on ECMO because we kept giving fluids to improve the flows. So finally we realized it's becoming a vicious cycle. So we put another femoral cannula, so both drainage, to pull out more blood, which were going into the oxygenator, and from the oxygenator back into the internal jugular. So the message is, choose the widest cannulae and the longest for you to get good flow. The return, of course, can be shorter, but you need very good drainage cannulae so that your flows are adequate. And we will show you all in the demo. Plus, as you progress in the lecture, different lectures, you will understand what he meant just now by the mixing cloud, etc. Any other questions? If not, we'll move to the next speaker. Next speaker. You can stop sharing.
Yeah.
Krishna, Dr. Krishna is here. Yeah.
Yes,
Thank
ma'am.
you. Thank you, Ravi.
Thank you.
Krishna, you can start sharing.
Yes, ma'am.
So we will start with the simpler. You will have VV ECMO, which is a lot simpler than VA ECMO. And happy to introduce Dr. Krishna. Thank you for joining the ECMO workshop of Pedicriticon. He is an additional professor in the Department of Pediatrics and ICU, Pediatric Intensive Care at AIIMS Bhubaneswar, with extensive experience on ECMO. Over to you, Krishna.
Thank you, ma'am. So, am I audible, ma'am?
Yes, you are. You have to enlarge, make it full screen, your slides.
Okay. Yes, I made. Now, screen is okay, ma'am?
Not yet. Yeah, press that. Yeah. Not
It's
yet.
okay.
No, it's not full yet.
So you can put it in a slideshow mode, sir.
Yeah, I kept in the slideshow mode only.
It's not yet.
Now it's okay, ma'am?
No, not yet. If not, we just start with this only. Sure. No,
Yes, ma'am,
not yet.
that's
But it's okay. It's still visible, very clearly visible.
okay. Thank you very much. I must appreciate my previous two speakers. They made my life very easy. So, if we talk about VV ECMO, just I would start with the statistics what ELSO registry says. If you go to the ELSO registry website, you can look at the dashboard of ELSO registry. You can see how many number of ECMOs being done worldwide, and they get updated very frequently. So if you look at till now that if there are on the upper side, you have some options to filter as a filters, total number and modes and from which part of the world they are doing ECMOs. If you look at these numbers, till now, all if you look at all mode of ECMOs, total number of 2.3 lakhs ECMOs were done, and out of which the pediatric considered around 41,000 and pulmonary is around out of which pulmonary around 15,000, cardiac around 20,000. This is what the latest data as per the ELSO. And if I clicked on the option of only VV ECMOs, till now around 80,000 VV ECMOs being done, and out of which around 8,500 from the pediatric population for pulmonary reasons, around 8,000. And if you look at our own SWAC also, that means the Southwest Asia and African chapter,
Your slides are
if you
not
look at the
moving,
number of
Krishna.
VV ECMOs here,
Krishna, your slides are not moving. Is that slides are not moving? Now they are. Can you also press the full screen in the right corner?
yes, ma'am, I did it, but
It's not moving.
they're
Okay, that's fine. But now they are moving. Now the slides are moving. Sure.
moving, ma'am.
Now they are
Now
moving.
they're moving. The case details.
Case details haven't come yet. This is the ELSO live registry that we can see.
Yeah, I think there's some problem, ma'am. That's okay. Then I will continue with this only.
Sure.
I will stop this. Now it's okay.
Yeah.
Now the slides are moving, ma'am.
Yes. Now it's fine. Now it's
So
fine.
if you look at,
Yeah.
if you look at our own SWAC also data, so even though the reporting from our region may be a little bit less, even then also if you look at the number of VV ECMOs done in adult and pediatric, it is amounting almost 3,000 patients. In that, the pediatric constitutes around 168 for the pulmonary indications of VV ECMO. So that means we are still lagging behind the adult population, but I think we hope in future we will increase the number. So to look at this VV ECMO, I will start with a case, and simultaneously I will be talking about the physiology of VV ECMO, and then so that it will be a better understanding for every one of us. This is one case. This is one baby we managed in last month. It is 3 years old boy, weight of 15 kilograms. He was diagnosed with amyloidosis and he was on Septron and doxycycline for last 4 weeks. And again, admitted to us with fever and cough for 5 days. And he had one episode of GTCS for one day private admission. And he had tachypnea, retractions, saturation of 82%. And max had saturation of 91% on 10 liters of non-breathing mass oxygen, and to reduce on the left side, and he was hemodynamically stable, and rest systems are within normal limits. So he was a respiratory failure when he came to us. So in the emergency, HFNC was initiated at 20 liters per minute with a fever of 60%, and IV fluids were started. Injection ticoplanin, meropenem, oseltamivir were added. In the next 1 hour, there was some slight improvement in the tachypnea, but still he was on oxygen dependent. And hence PSU call was sent for the further management. So he was shifted to PICU after 4 hours. When he came to PICU, he was still tachypnic, saturations are low, incubable breathing, and he was continued as HFNC by the PSU team. There was no improvement. So in view of incubable breathing, the treating team started NIV with PEEP of 6, that increased to 8 over next 2 hours. The delta P of 10 increased to an 18 and FO of 100%. So the child was so irritable, started dexmedetomidine infusion at 0.5 mg per kg per hour. Child was hemodynamically stable. In the next 1 hour, even though you look at the blood gas, it looks a little bit okay, but there is no much improvement in the workup breathing. So they went ahead with intubation. So initially started with pressure control mode of ventilation, SM with pressure support mode, 100% FiO2, PIP of 20, PEEP of 7, and respirator of 30. Closed suction was attached. Femoral, arterial, and venous lines were inserted. After intubation, he had poor pulses, most probably related to the sedation. Fluid bolus was given, and adrenal infusion started at 0.04 mg per kg per minute. So if you look at still the saturation of 94% on FiO2 of 100%. That means if you have the PF ratio of 76, OAR is around N17, and lactate of 2.5. This is the first X-ray we had. You can see the left side of lung collapse on the left side, right side little bit okay. And because it is differential lung involvement, it becomes very difficult for us to ventilate with conventional mode of ventilation as well. Because if we increase the pressures, the other lung will get damaged because the majority of the pressures will get transmitted to the healthy side. So ventilation titrated for next 1 hour or so. So they titrated the P for the best compliance that was coming out 7 to 8 centimeters of water. The PAP of 23 centimeters of water. Saturation is still 88%. PF ratio is around 107. We are not able to reduce the FiO2 below 90%. Echo was normal and a plan for prone ventilation. So our team we will start prone ventilation and then see what will happen the next few hours or so. So in the next 8 to 10 hours, so we plan to monitor him clinically, and we did blood gas after prone ventilation. PF ratio is still 120, OI is increased to 29, and HFO was initiated on prone ventilation, and even then also child was not improving. So we thought that we should prepare ourselves for ECMO because it takes some time for in our setup to prepare ourselves. So we need to prepare for initiation of ECMO. Because he is hemodynamically stable, we thought that we will go for VV ECMO. So if you look at the indications of VV ECMO, we know that in spite of your best effort on conventional mode of ventilation and ancillary therapy in the form of good sedation, paralytic agents, maintaining a hemoglobin more than 10 or so to improve oxygenation, to improve oxygen delivery to the tissues. In spite of all those things for next 4 to 6 hours, even if your PF ratio is less than 75 and if your OI is more than 40 and your lung compliance is very less than 0.5 ml per kg per centimeters of water, and your ventilation index more than 40 and your arterial to alveolar gradient is more than 600 and you are having hypercapnia with PS less than 7.15 or so, and there is no response to the conventional ventilation, then you think that this child is probably the candidate for VV ECMO and I need to go for alert the team, my team to start VV ECMO. The important thing I need to reiterate that you need to do everything possible on conventional, on HFO, on INO, or prone. You do all the things. In spite of that, also, if you're not able to go for maintain the saturations and oxygenations and oxygen delivery or hypercarbia, then only you will think for going for VV ECMO. I'm very clear about the indications. And if you look, but when do you not go for VV ECMO? For not for VV ECMO, for any ECMO type of ECMO, when ventilation is more than 14 days, again I wrote it as relative contraindication. It all depends upon how much pressures the child was getting during those 14 days, how much FiO2 the child was getting during that 14 days. That needs to be a individualized approach. So that is not an absolute contraindication, it is a relative contraindication. But if the child has severe DIC, multi-organ dysfunction, severe MODS, malignancy that is incurable, preterm babies, less than weight 2.5 kilos, we do have those who have massive IC bleeds, vegetative states. So in these conditions, you think that VV ECMO or VA ECMO is not a suitable option for these type of patients. So how does VV ECMO works? That is what we need to look at. So what it does is, as the previous speaker said, the blood is taken out from the body, it get oxygenated in the oxygenator, and it's given back to the patient. So here what we are doing is we are doing the gas exchange, that is CO2 removal and oxygen delivery in the oxygenator, and it's giving back to the patient. And same time we are giving rest to the lungs to heal itself, so that we will otherwise the main purpose of VV ECMO is to give the rest to the lungs, so that the lung injury which we produce by giving the high pressures and high FiO2, that gets limited. And that is the reason in this way we can protect the lung and heal and make the lungs to heal by itself. So if you look at this one a schema diagram, always I tell to my residents that if you look at, so if you think it as IVC, I'm draining the blood from the IVC, that is deoxygenated blood, that is and here that get oxygenated in the oxygenator, and it's given back to the patient. The red ones are the oxygenated blood. So in the RA, so you will have the mixture of oxygenated blood as well as the deoxygenated blood that is coming from the IVC and SVC. So this oxygenated blood that goes to the right ventricle, and then it goes to the lung, where it gets oxygenated. The amount of the lung, whatever the amount of lung that whatever the amount of oxygenation the lung can do, that will get further oxygenated, and it will give and it will go back to the left atrium, left ventricle, and then it will go back to the system circulation. So it is, you need to understand here that the right side of the heart will get oxygenated blood from the ECMO, and the native circulation that is contained deoxygenated blood from the system circulation, the both get mixed here, and that will go to the lung and further oxygenated if the lungs are working okay, and then will go back to the left atrium. So here how the oxygenator works here, it is like, just imagine that the oxygenator is just like your dialyzer, because we are more often to used to see the dialyzer. In a similar way, the oxygenator is equivalent to your dialyzer. That's what I can ask you to imagine. So here there will be a blood flow in the tubules, and there will be a blood gas, that is the gas flow, that is called a sweep gas, that contains that comes from the oxygen blender. So that contains 100% FiO2. Depending upon how much amount of FiO2 you have kept, that will give that much amount of FiO2 on the blender. So, and then in between there will be humidified water that will be flowing to maintain the temperature. So there are three components that get mixed in the oxygenator. One that is the blood flow, another that is the sweep gas that containing oxygen, and other one is the humidified water that maintains the humidity. You just imagine that this humidified water is equivalent to your humidification that we use in the ventilation. So once, because when the blood flow goes side by side, airflow also goes. It is just imagine like a dialyzer. So in the one part you're going, the blood is going, and other part your dialysate is going in the counter direction. In the similar way, so when the blood is going in one direction and your sweep gas is coming in the other direction, the gas exchange will occur across the membrane. That is, your CO2 will come out from the blood to the gas, and your oxygen will go from the sweep gas to the blood. So here the gas exchange takes place, and the temperature is maintained by the water flow, that is humidified water flow, that is given from the externally. So this is how the oxygenator works. So as I told you earlier, this because the right side of the heart gets oxygenated as well as deoxygenated blood, and it will go to the lungs. So that means the pulmonary arteries get oxygenated blood compared to the native circulation, where in you and me, where the pulmonary arteries get only deoxygenated blood. But when in the VV ECMO, what happens here is you are getting the both oxygenated predominantly and some amount of deoxygenated blood that is going to the pulmonary circulation, so that it will increase so that it will dilate the pulmonary vessels, so that it reduces the pulmonary vessel resistance and reduces the right ventricular afterload. At the same time, when there is good amount of oxygen is going on to the lungs, so you will have the inflammation in the lungs secondary to the pneumonia or whatever it may be the reason, that gets reduced. The similar way, so because now the lungs are getting the oxygenated blood, ultimately that they are going to the left side of the heart, so coronaries will get good amount of oxygenated blood. So the cardiac function will be on the better side. So this is how the VV ECMO works. So when you are getting oxygenated blood that is going to the pulmonary circulation, it will reduce the pulmonary vessel resistance and reduces the after the right ventricle, and it makes right ventricle to function better way and reduce the inflammation in the lungs, and as well as it increases the oxygen to the coronary, so that left ventricle function for the cardiac function will be little bit on the better side. So at 24 hours of the ICU stay, coming to our case again, the family is counseled and the consent are signed for the VV ECMO. And again, now we have, as my previous speaker had said, so which site you cannulate and what size cannula you will choose and what circuit you will choose. Again, these are all the questions that we arise when we start for the VV ECMO. So again, what any special consideration that we need to take when, because the child here is around 3 years and 15 kilo, it is just borderline. And what are the other considerations that you are supposed to look? And again, and meanwhile, our resident brought a chart of the cannula size. So this is the cannula size chart. Then you can simply choose, pick up one cannula and then insert in the patient. So do we agree that the simple chart that has been designed for the Western population that becomes fit into our population, where the malnutrition is very much high, that the development of vessels is little bit different from the Western kids. And when we need to go for double site cannulation or single site cannulation, that again, these are all the questions that needs to be addressed prior you jump into putting a patient on the ECMO. So here, the simple chart as shown by Dr. Ravi previously. This is for the starting point again, but what I suggest is that it is always don't go blindly by the size of the patient or age of the patient. Just measure the diameter of the vessel using ultrasound, and if you the size that you get in millimeters, if you multiply it 3, that will give you the French. Then you choose the appropriate French cannula according to the patient's vessel size. So in our patient, the right ICU diameter was around 4.8 mm, and the right femoral vein diameter was around 2.8 mm. So that's why we have taken the around 13 mm of 13 French of cannula that we use as a drain into the right ICV, and 12 French femoral vein for the return. So usually what happens in the adults we do is we take from the IVC and get oxygenate in the through the ECMO, and then we give back to the ICV. So this is the routine, the classic thing that goes in adults in the double site cannulation. So here the amount of recirculation is very less. I will be dealing with recirculation in the next few slides. How do you tackle with recirculation as well? So this is what the classical people do. So here, but we as the child is small and the femoral vessels are less developed, so we thought that the drainage from the femoral vein will be inadequate to support the flows. That's why we have taken. That's why we chose ICV as the drainage cannula and femoral vein as the return cannula, so that it will the drainage will be, the flows will be better. But even the chances of recirculation are a little bit higher in this mode of cannulation. But that was not the problem with our case, because our the return cannula that we kept was way below in the inferior vena cava. So that there was no, we didn't get any problem with recirculation. So this was already discussed with Ravi. When you have the problem, when you cannot cannulate jugular vein, and that is neck veins, that is especially in the patients with the neck injuries and autonomic dislocation with the ARDS. In those patients, you can consider for bifemoral cannulation. That means you can take out the patient from one femoral vein. You insert the drainage cannula. That is still that shouldn't go beyond the IVC, SVC, IVC and RA junction, and try to keep as low as possible. And the return cannula, it is you insert so deep into right atrium so that the blood will directly go into the tricuspid wall. So even though there are chances of recirculation, but you need to accept the amount of recirculation and then go ahead with the treatment. So again, it was the double single site cannulation that was explained, that was already explained by Dr. Ravi. So I am not going to detail into this. And this is what I was telling about recirculation. So if you just imagine, you look at this diagram, for example, this is the inferior vena cava. You have taken the blood from the inferior vena cava, and it is going to the ECMO, and is going again back to the IJV and into the right atrium. So normally what happens here is, what should happen is, this oxygenated blood should predominantly go into the tricuspid wall and to the right ventricle and to the lungs and to the left ventricle. So here what is happening here is, the oxygenated blood that is coming to the right atrium, it is again being sucked by the drainage cannula into the ECMO circuit. So the oxygenated blood is going on circulating in the ECMO circuit. That means, and the patient is not getting the oxygenated blood into the right atrium, into the right ventricle, and to the lungs, into the left ventricle, and ultimately to the left side of the heart. So this happens in 2-3 conditions commonly. So if your drainage cannula and your return cannula are very close to each other, so if the amount that is returning to the cannula, it is being sucked by the drainage cannula. So always look at the distance between the return cannula and drainage cannula. It should be more. It should be at least 5 to 7 centimeters, so that the amount of recirculation will be less. At the same time, if the heart rate is very high, then also the chances of recirculation becomes very high. These are two common conditions where you see the recirculation. That is, when your return cannula and drainage cannula are very close to each other. When your heart rates are, that means when your cardiac output is very high. So when the blood circulates very fast, the chances of recirculation are very high. So this is the formula to measure the recirculation. That means this is saturation in the pre-oxy. That is the saturation in the drainage cannula side, and the saturation SCO2, that is the patient, it is the SCO2 that you get from any mixed venous saturation from the patient's body, and the SCO2 in the pre-oxy, and in the post-oxy. Here you take saturation from the return cannula. So the saturation from here, the saturation from the drainage, and saturation from the patient, if you that is mixed venous saturation, if you have these 3 saturations, you can calculate the amount of recirculation. You see, there will be some amount of recirculation is inevitable. If it is more than 20-25%, that means that it is not acceptable, and then you need to take some measures to reduce the recirculation. That we will be discussing in the hands-on workshop in Chennai. So the case is continued here. The right IJV and right femoral vein were cannulated successfully. As soon as the guide wire was inserted, 500 units of heparin bolus was given, and again which circuit you need to use. Usually, there are 3 circuit sizes are there. That is 1/4 diameter, 1/4 inch diameter, 3/8 inch diameter, and 1/2 inch diameter. So in pediatric population less than 10 to 15 kilo, we use 1/4 inch circuit along with pediatric oxygenator. If the patient is more than 15-20 kilos, we can go for the adult circuit, that is 3/8-inch circuit and adult oxygenator. And other is how do you prime the circuit? So always it is preferred to prime with blood in case of pediatric population, especially less than 10 to 15 kilos. It may not be a problem with adult cannulation and adult ECMOs. And again, it is better when you prime, avoid whole blood to avoid hyperkalemia. And you may prime with albumin also prior to blood priming. It reduces the chances of circuit-related inflammation. So in our patient, the blood priming was used, and after that, everyone we get in the question in your mind is what the flow you should be using. So that means the amount of the blood that you take from the patient, that is called as ECMO flow, that will go to the oxygenator, to the pump, and then get oxygenated, and that will go back to the patient. So usually the typical flow rates for pediatric and smaller babies is around 100 to 150 ml per kg per minute. But when you start with little bit lower rates, around 40-50 ml per kg per minute, and gradually will increase over the next few minutes or so, depending upon the patient's tolerance of hemodynamics and the saturations. So always start with gas flow, that is around 50% of your blood flow, and then you accordingly you will increase based upon your PCO2 levels that we will discuss in the workshops. And ECMO effort should be always 100%. So by dictum, if you start with VV ECMO, it is full support. And for VA ECMO, it is half or 3/4 support, because you want the native heart to work. That's the reason it is not always the full support in the VA ECMO. In VV, it is always full support. Over the next 30 minutes or so, the flow was gradually increased to 1.3 liters per minute, and the now saturation was gradually improved to 96%. So again, we should start with low flow, because if suddenly, because the child is on hypoxemia for a certain time, and if you make full flows and high FiO increase, suddenly the PaO2s to all the body is accustomed to low saturations for some time, low PaO2 for some time, that is around 40s, 50s PaO2s. And if you increase suddenly to 150, 200 or so, what will happen here is it will cause vasoconstriction. And so the systemic hypertension may occur. Sometimes it will increase the outflow to the left ventricle. So we don't want the PaO2s to rise very suddenly. At the same time, we don't want the CO2 to drop very suddenly also. If you, for example, the patient was on the higher CO2s, around 60, 70s prior to ECMO, if you reduce drastically to 35, 30 or so, it will cause vasoconstriction, cerebral blood flow changes, and it may cause IC bleed if the patient is smaller babies whose vessels are a little bit fragile. So to avoid those complications, we need to be a little bit slow when you start over the next 1 to 2 hours to improve the oxygenation and to reduce the CO2s. So if you look at in our index case, this is the ICV cannula that is just into the right atrium, and the femoral vein that we used for the return, that is lying very, very low in the pelvis. That is, it is still in the femoral vein only. So there are a lot of difference between the drainage cannula and return cannula. So the chances of recirculations are very, very minimal. So this is the saturations after 3 hours of ECMO run. Saturation improved to 96%. Hemodynamically stable. The blood pressure on a little bit higher side, which we expect in the VV ECMO, and the flows are around 1.3 liters. This is the from here we were draining from the ICV, and it is from here we are giving back to the patient. You can see a little bit color difference. It is dark. The drainage is dark, and after oxygenation, it is brighter one. So after that, what ventilation settings we need to consider, that will be dealt by Dr. Kalyan in the last lecture. So by and large, what we want is, we want the FiO2 to be less than 40 to 50%, and the plateau pressure less than 20-25, so that there will be lung rest. This is what I won't go very detail into it because Dr. Kalyan will be covering in his lecture. So in this patient, we went after the initiation of ECMO, we went to PCV mode with rates of 20, PEEP of 6, ITM of 0.8, delta pressure of 12, and FO of 40%, and the compliance was 3.2 ml per kg per centimeter water pressure. And how do you monitor whether the lung is improving or not? When you this one putting the patient on ECMO is one part, and other thing is that how do you monitor the lung improvement? So the classical indices which we use, PF ratio, OA, are not useful because here the lungs are not working properly, and the major work is done by the oxygenator and the by the oxygenator. So what we are supposed to look at here is the compliance. How is the lung compliance improving? So over the next few days, whether it used to be around 3, for example, in our patient, the compliance was 3. In the next 5 days, 6 days, it improved to 9, 10, 12. That means the lung compliance for the given amount of pressure, the tidal volume is increasing. And you do the X-rays every second day, third day, see the lung clearance, how it is occurring. These are the predominant features that we see whether my lung is improving or not. And for the oxygenation, and if you have the facility of ETCO2, you attach the ETCO2. So if the ETCO2 is increasing, that means that there is oxygen, there is ventilation is being occurred in the native lungs. That's the reason the ETCO2 is gradually improving. So these are the 3 parameters that we see whether native lung is improving or not. One is the compliance, second is raise of ETCO2s, and other is your chest X-ray clearance. So other important thing here, you can give the oxygen challenge test that we will be discussing in the workshops. So again, the anticoagulation will be dealt by our my colleague in the next few slides in the next lecture. So for this, we have given started infusion of 7 units per kg per hour. The ACT was 147, and we have given a bolus of 150 units per kg, then followed by 10 units per kg per increment in the infusion, and our AC target was around 160 to 170. This is a chart that you can get from any standard textbook how to titrate the heparin dose. So on the day 3, started to have the bleeding from the IJV and the femoral and from the central line sides. So we had to transfuse FFP and platelets. And after in the next 24 hours or so, we reduced the heparin dose, and subsequently these bleeding complications got reduced. So this was the day 4 X-ray. The left lung completely gone now, and the right upper lobe, there is a pulse consolidation is there. Because the patient is an ECMO and anticoagulation, we may not be very aggressive in doing physiotherapy. We did alternate every third day bronchoscopy to suck out any secretions or any clots or so. Fortunately, there were no much clots. There was a little bit secretion that we used to suck it out every third day, fourth day. So by day 7, you can see there was some saturations were improving 100%, and compliance is increased from 3 to 9. And you can see there is you can see the aeration on the left side of the lung. So by the next day 7 or day 8, these things gets started to improve. And by day 10, we increased the reduced FiO to ECMO 50%, reduced the gas flow to the 500 ml per minute, and we gradually increased our ventilator settings. Rates increased to 30, delta increased to 15, PEP is 6, FiO to 45%. And we had some issues with coagulation, the ACTs. The ACTs were in the latter days, the ACTs was persistent on the lower side. So we had to increase heparin up 35 units per kg per hour. Still then, there was no ACT was still on the lower side. So in the condition, we need to think of antithrombotic deficiency, and further we had given FFP, and subsequently the ACT got normalized. And these things will be discussed by Dr. Shobhadeep in his next lecture. So by day 12, we stopped the ECMO. And on this settings of ventilation, the compliance was around 12, the PF ratio was increased 150 to 200, and by day 13, we could decannulate the patient. And the tracheostomy and by day 14, currently in the room air. So at 30, sorry, this is. So if you look at this is how, if you talk about the meaning of VV ECMO, what we do is, once you think that the lungs are improving, that means the compliance is improved and your ETC is increasing, chest is getting cleared, then you reduce the ECMO settings. I suggest that we should not fiddle with the ECMO flows, because in the pediatric population, we go with low flows, the chances of clotting are on the higher side. So always you reduce the FiO2 on the ECMO side in the blender, and then cut off your gas flow, and then see how the lung mechanics are going on and how the lung is maintaining the oxygenation and the ventilation on the moderate settings. That is your FiO2 of around on around 50 to 60%, not more than that. PEEP of around 6 to 8, and your P plateau less than 25 or 30. In those settings, how your native lungs are behaving, and if you're satisfied with that progress, and if your PF ratios are more than around 150 or 200, then you can safely say that your lungs are improving, and you can go back and you can come out of the VV ECMO. And again, I need to emphasize that we are more comfortable on ECMO, but you need to understand that there are other complications related to the ECMO, in especially in our setup, there are infections. So come out of ECMO as early as possible without wasting much time, and you will continue the routine ICU care as you do for routine other patients. So the complications are again the bleeding and clotting that we commonly encounter, predominantly bleeding, the sepsis, the recirculation part that we have, how to go about it, that I will say in the next slide. And you may have cannula kinks and clots. So again, in the adult world, they go for awake ECMOs, but it may not be practically feasible in pediatric population, because adult you can say them to listen to you, but pediatric children of 2 years, 3 years, just you think, do you think that these kids will listen to you? They will not listen. They will pull out the cannulas and all those things. So I think the awake ECMOs are still far away from pediatric population. And you may have pump head clots, oxygenator failure, oxygenator leaks, and coagulopathy related to oxygenator, and hemolysis. So these are the all problems you may face when you are running on ECMO. So this is one of the last slides I wanted to emphasize. Even if the patient is on ECMO and he's having hypoxemia, saturations are less than 80 or so, so what you're supposed to do? Always look for the reversible causes like connections, whether ECMO blender connection from the oxygenation, from the blender, the oxygenator connection got disconnected or not. That is the most common thing, common reversible things you're supposed to look at. And then you look at the delta pressure. That means the pressure between across the membrane. So there's a delta pressure, that is pre-membrane minus the post-membrane pressure, how the pressure is lost across the membrane. If it is normal, then look for recirculation. Recirculation is there, and you reposition your cannula and reduce the flow and reduce the cardiac output. If there is no recirculation, if you check the pre-pump pressure, that is more negative, that means you give some fluid and see how the things are behaving. If your delta pressures are high, that means there is a problem with your oxygenator. That means there is some clot or so. That means you need to change the oxygenator. There is no other option for you. And if your post-oxygen saturations are less, that means less than 200, then you need to add one more oxygenator in the series, improve saturations. If your post-oxygen saturations are more than 200, And if your lactates are normal, even if your saturations are on the lower side and 80, 75, 80, 85, then nothing to worry. You need to wait and watch, provided your lactates are okay. And but your lactates are high, then you need to have backup for going to VA ECMO, or you have some other options to reduce the body metabolism in the form of you can induce the hypothermia so that the amount of oxygen that you are giving to the patient that is sufficient for the body needs. So again, these approach that we will discuss in the hands-on session on 12th December. So what I wanted to conclude from my slide is that the start early in the course, start the ECMO early in the course of disease on ventilation, and choose the cannula and cannula site wisely, and reduce settings, ventilation settings as much as possible to the minimum level, and daily watch for any bleeding or cannulation migrations, etc. And always look for the native lung recovery, whether it's improving or not, and prepare yourself for hybrid modes if necessary, and remove as well as possible, and that we do for any other bundles in ICU, like a central line bundle, VAP bundle, catheter bundle. Always think whether always look for, always take a chance when to remove the ECMO from the patient as well as possible. And I thank you, pediatric team, to give this opportunity to present this case. Thank you very much.
Thank you, Krishna. Any questions? There are some in the chat box, Krishna. What limit of hypertension is acceptable in VV ECMO? Because that is the one, apart from recirculation, that is very commonly encountered, especially in pediatrics. Do we need to treat if more than 95 plus 12 centile?
Yes, ma'am. It is nothing any different from any other ICU patient that we manage. So if the hypertension is there, it is because there are that can be because of a number of factors. The hypertension, because you are given a lot of fluids, one, and other is you are disturbing a lot of humoral factors in the body by using extracorporeal circuit. Again, the etiology of hypertension is very minimally known. The etiology why it occurs in the VV ECMOs, but it is well documented that you have hypertension. You will treat like any other hypertension in the ICU. Because if you hypertension, your patient is anticoagulation, the chances of bleeding may be high. So it will be a little bit aggressive by using SNP and labetalol also. But again, because you have a lot of big amount of ectopic circuit is there, the absorption of the drugs will be high. So you need to be a little bit on the higher doses that what we routinely use for the ICU patients. But in this patient, we had to use SNP up to 12 mics per case per minute. That is, which we don't usually go beyond 5 to 7 or so.
Yeah, so we use a lot of enteral. If the gut is fine, we use enteral antihypertensives because that will not
Yes.
be sequestered in the ECMO circuit. So labetalol infusions with SNP, and then of course all enteral antihypertensives. Recirculation, of course, you have mentioned. Very easy. What we say is you eyeball the drainage and the return. If both are red, the drainage should be blue, dark, and the return should be red. If both are red, then you know recirculation. If both are dark and the SAT's low, that means some oxygen connection or something like that, because it's not getting oxygenated.
Yes, ma'am. Fortunately for this kid, from the day one of ECMO, he was on full feeds. We never stopped feeds for this kid.
Yes, so very important, early enteral nutrition to prevent gut translocation, etc. What's the range of blood flow and gas flow we use in neonates?
So for, as I said earlier, for smaller babies, we start in the around 120 to 150 ml per kg per minute. And the gas flow, usually we start with half of the blood flow. And then depending upon the CO2s, we change it. Usually the gas flow, we don't go twice or 2.5 times that of the blood flows. because it will cause, if you give very high flows, there may be chances that the membrane integrity may get lost.
Yes, and very important point which Dr. Krishna mentioned, do not aim to normalize the gases immediately after you cannulate, right? I mean, connect to the ECMO. They have found that if the CO2 drops to more than, less, I mean, 25 millimeters of mercury from what was the baseline. So if you had a 120 CO2, it should not drop below 95. If it drops below that much, below 25 millimeters in the first 3 hours, there is higher risk of CNS injury. You can have stroke, you can have intracerebral bleed and other neurological problems. So the key is not to drop the CO2s rapidly. That is very, very important. So the sweep gas, don't make it 1:1, the blood flow and the sweep. Turn it up very, very, increase it very slowly, especially if the CO2 has been very high. That's a very, very important point.
So there is somebody asked, Dr. Prakash was asking regarding PEEP 10, PAP 50, and rate of 5 use units. Yes, sir. What I wanted to say here is that if you look at the evidence for the ventilation in the ECMO, every unit has their different policies they follow. So commonly people use rule of 10, that is 10 rates, 10 PEEP, and 10 delta P. This is what people commonly use. And there's some units there where they use 0 PEEP and they completely shut up the ventilator also. There are some units, they keep 20-25 of PIP, PEEP of between 6 to 8, 6 to 10, rates of 15-20. So all these things, the parameter combinations, it all depends upon unit where you work. And again, so how much, for example, how much part of ventilation you want to take. For example, you have your flows are limited. For example, in this patient, I was happy that because we do not have the facility for VA, so we have some compromise regarding the cannula size and the flows. So we thought that we will go with a little bit lower flows. We accept the lower flows, even the flow of 1 liter is also okay for us. And with that, we will do oxygenation and ventilation. And the moderate settings of ventilation, we will let the lungs to work to some extent, so that when the lungs work as well as your ECMO works, so ultimately the system circulation, the system oxygenation will get better. So it is, again, there is no hard and fast rule that it has to be these settings you are supposed to follow. Again, it all depends on the patient's condition and what you need and how much you want the patient's lung to work.
Question, sir, please explain sweep gas settings on ECMO and other knobology settings. That I think when you see the machine, you will understand it better.
Yes, ma'am.
Any other questions? So driving pressures are very important. So the aim of your ECMO for ARDS is lung rest. And if you have air leak, as Dr. Krishna mentioned, you won't even want to give any pressures. You just want the lungs to heal. So that is the basic aim. No point doing regular ventilatory settings if you are putting a patient on ECMO. It defeats the purpose of ECMO, which is basically lung rest and letting the lung heal and reducing the inflammation. So now we've talked a lot about the lung. Another very important organ is the heart. So over to our next speaker. Thank you, Krishna. Shubhadeep, are you here? Yeah, I can see you.
Yes, ma'am.
You can start sharing.
Yeah.
Yeah.
As Krishna stopped his screen sharing. Yeah.
Yeah.
Okay.
Yeah, stop it.
Is this visible?
No, it's not. It's not sharing yet, Krishna. Shubhadeep.
Okay. Okay. Just give me a few
Yeah,
seconds.
you are a co-host. Yeah.
Yeah.
It has started screen sharing. Yes.
Huh?
You have to make
Yeah,
it full
okay.
screen. You have to make it full screen.
I'm doing that, ma'am. I'm just going to the first screen. I'll do that.
Yeah.
Just go to the first slide. All right.
So it's my pleasure to invite and introduce Dr. Shubhadeep Das. You can see from his extensive his certifications and degrees here. He's a senior consultant, clinical lead of the pediatric cardiac ICU and the PICU, as well as pediatrics in Calcutta. Which hospital, Shubhadeep?
Ma'am, I'm working in Narayana,
Narayana.
Kolkata.
Yeah, that's right. That's right. So over to
So
you.
you can see the template of my presentation. So that says Narayana Health.
Oh, I think that is not visible below to me, at least. I don't know why.
Okay, okay. Maybe in the
Yeah, I think because of this chat thing that comes down,
maybe
no?
in the subsequent slides that will be
Yeah. Okay.
right.
Over to
Yeah.
you, Shubhadeep.
All right, ma'am. Thank you, ma'am, for the very kind introduction. And I would like to thank you, ma'am, and also the organizers of PediCriticon 2024 for giving me this opportunity to speak on this platform. And in fact, the speakers before me, Krishna, Dr. Ravi, and everybody else, they made my probably made my life a little bit easier because they have explained they have explained most of the basics of it. So what we will do is that we will talk about indications and contraindications of ECMO. We will talk about what are the advantages and disadvantages associated with that. Talk about some basic physiology while a patient is on ECMO and some basic knowledge which is necessary to wean a patient of ECMO. Remember, like we have an entire session and also a hands-on session on how to wean patients from ECMO. So I'll just touch that aspect and not go into a lot of details. So what I will do is exactly what like Krishna did. I'll just walk you through a case, and this is a real patient which we managed a couple of months ago. So this was a 3-year-old boy, 12 kilo, suffering from severe myocarditis, was paraflu positive on viral biofire, on pneumonia biofire panel. And you can see the lungs on the chest X-ray looks quite bad, pretty white out, as well as we can probably appreciate that there is a bit of cardiomegaly and on mechanical ventilation on pretty high settings, 100% FiO2, with which he was saturating 90 to 92%. The LV ejection fraction was only around 25%, and we were on very high doses of inotropes and pressors with adrenaline, noradrenaline, some milrinone. And with this, his mean arterial pressure was in the low 40s. His lactate kept gradually climbing up from 3 to 4.5 up to 8. And his mixed venous saturation was also very low. He was oligoanuric. So with this background, what would be our thoughts on whether this child is a candidate to be cannulated onto ECMO? If the answer is yes, what kind of ECMO would it be? And if we at all cannulate the patient, how would we cannulate our patient? All right. So in order to answer these questions, let me just briefly tell you about what are the risks and benefits of ECMO is, because whenever we contemplate on putting a child on ECMO, we need to be aware about the benefits and the risks associated with that. So we always, in such a scenario, right, we would jump and start discussing with the family about the options of ECMO if we have that. So what we need to realize is ECMO is not like an antibiotic which you give to the patient and the patient will heal, right? So what it does is it only provides you with very valuable time, a physiologic milieu, and allows your body to heal, right? So it's not a therapy per se, but it's just providing that environment when your body gets ample time in order to get better. So that is the benefit that we are offering the patient. But we also need to be cognizant about what are the risks, because then only we can initiate a fruitful discussion with the family. So what are the risks? We have already talked about this in the last 3 lectures. So because we are violating an artery, because in case of ECMO, because we are violating a vein, so there will be always mechanical risks, because we are anticoagulating the patient and the patient may be already coagulopathic. So there will be chances of hemorrhage. There can be thromboembolism. We can produce non-existent end organ damage, which were end organs which might have been functioning completely well. We can produce damage to them. Like renal damage, we can produce damage to the heart, we can produce damage to the lungs. We can also give infections because we are violating so many vessels, and we can also cause limb ischemia, as was demonstrated in the lecture on cannulation. And then always we kind of are initially confused when we are initially in our ECMO days, like we are not yet very experienced. We always get confused with such kind of scenarios as I just demonstrated, or the one which Dr. Krishna demonstrated, like which technique to choose, whether it would be VA or whether it would be VV. Now, it has been dealt with already by my colleagues, how ECMO works. So how VA ECMO works is that VA ECMO, what you do is you are taking blood from a large central vessel, right? Or it could be from the right atrium also directly, which is part of central cannulation. And then what you are doing, basically, the blood pump, it is sucking out blood and then pushing blood across the oxygenator, which is basically what? Which is basically your artificial lung. And you are actually giving fresh air across the oxygenator, which is also known as sweep gas, as Krishna was showing, with a countercurrent mechanism. So what happens is oxygen is given in, carbon dioxide goes out, and what you are doing is now you are giving red blood, fully oxygenated blood back into the arterial system. Okay, so that is what VA ECMO is. So with that background, you can probably now think about where VA ECMO would be useful. It would be useful in pump failure. So what is pump failure? Where your heart is not working. So that is why you are entirely generating your cardiac output using VA ECMO. Plumbing failure, what is that? So it can happen in severe sepsis where your vessels are very dilated. You might have a completely functioning, well-functioning heart, but you are very, very vasodilated because of distributive shock. You are not able to maintain blood pressure. You are not perfusing your organs well. So these days, we also consider severe sepsis, septic shock as one of the indications of putting a patient on ECMO. And of course, you can consider in respiratory failure totally. So what are the advantages and disadvantages? So the advantage would be it produces both cardiac as well as respiratory support. And as a result, it gives complete recovery to your heart. It gives a rest to your heart. It gives rest to your lung. And you can generate consistent perfusion, consistent oxygenation. As a result, if you can do it properly, you can maximize the chances of end organ recovery because you are perfusing your organs very well with good oxygenated blood, right? And you are bypassing your lungs. What are the disadvantages? Because you are violating an artery, so that is why there are always mechanical risks of bleeding. You can have thromboembolism. Your blood flow to the vital organs, as I was mentioning earlier, can be impaired. And of course, so if you are not doing it properly, you can cause end organ injury. So already Krishna has dealt with this disadvantages of VV ECMO. It does not support your cardiac output. And sometimes even if you annulate a patient on VV ECMO for a respiratory cause, which could be ARDS, always remember, like ARDS, these patients have the potential of moving into a cardiorespiratory failure, developing multi-organ failure. So initially you are probably able to support a patient on VV ECMO, but if they transition onto having heart failure along with ARDS, then your VV ECMO might not be useful. Okay. So what are the indications of VA ECMO then? We have also talked about this briefly. So you could consider not only VA ECMO, but you could consider ECMO as a bridge. So because I'm talking about VA ECMO, so VA ECMO, what kind of bridge it is? It could be a bridge to recovery. It could be a bridge to durable mechanical circulatory support, decision making, or heart transplant. How is that? Like, for example, any scenario with a cardiogenic shock, it could be a myocardial infarction, it could be acute myocarditis, cardiomyopathy, it could be pulmonary embolism, it could be post-cardiotomy scenarios, it could be in-hospital cardiac arrest or refractory arrhythmias. Now, your ECMO gives you time, so acts as a bridge to recovery. You cannulate the patient on ECMO, it acts as a bridge, and then after a few days, your heart recovers, you decannulate the patient. So it is a bridge to recovery. Sometimes the heart may not be amenable to recovery at all. So these are typically the patients who are waiting on a transplant list. Sometimes they might have acute deterioration. So you cannulate the patient on ECMO, wait for a few days, you get a heart from a donor, and then you transplant the patient. And sometimes these patients might be candidates for durable mechanical circulatory supports, like we call ventricular assist device, which is out of the scope of this discussion. And the last one is not always a scenario which we face in countries like India, but decision making, there is something which is often done in the West, like the child might have deteriorated acutely, but you might not have an exit strategy. You cannulate the patient on ECMO. After a few days, you realize that you are heading nowhere. You initiate this conversation with the parents that, like we're probably heading nowhere. So you gradually go into a palliative path. So the indications of VA ECMO, as I was saying, it could be because of cardiac failure, it could be because of severe distributive shock, or it could be because of respiratory failure. So we can divide the indications generally into 4 broad categories. It could be in the context of cardiac surgery or catheterization. Say, for example, you have a patient who presents in an extremis but requires a heart surgery or a very complicated cath procedure. So you cannulate the patient on ECMO, you stabilize for some time, and then you take the patient for surgery or cath procedure. You will have far more better outcome, right? Second scenario could be you have completed a cardiac surgery, but you are unable to come off cardiopulmonary bypass. Sometimes you can have post-cardiotomy myocardial scanning. So you can convert your cardiopulmonary bypass machine into ECMO, and you can bring back the patient to ICU. But before doing that, you need to be rest assured that you are not missing out any residual lesion. So your surgery has went well. There is nothing from a surgical perspective that you can fix at this point of time. And then you're still, if your cardiac function is down, very down, you are maxed on your inotropic supports here, you can the patient on ECMO and bring to ICU. All right. And in the ICU also, when you have brought the patient back, sometimes it might so happen that the patient is not moving in the right direction. The patient is entering a low cardiac output state. You are very much limited on your inotropic supports, and then you put the patient on ECMO. Again, there could be some situations where you have refractory cardiogenic shock, which could be due to myocarditis, acute cardiomyopathy. You are on high inotrope supports. Despite that, you are having poor perfusion, increasing lactates, decreasing mixed venous saturation, oliguria. Those are the typical situations where you cannulate the patient on ECMO. Again, as was mentioned earlier, do not wait for the patient to become anuric. Do not wait for liver damage to set in, because now what happens is, like from low cardiac output state, from a myocarditis, if you are not perfusing your organs properly, then you will have a multi-organ dysfunction. So the chances of recovery becomes lesser, right? And as I had mentioned, it could be used as a bridge to heart transplant. And also nowadays, this has become a very relevant indication also in India in hospital cardiac arrest, where you have set up, then you can use ECMO, which is called eCPR. All right. So now we have looked briefly into few things. With that background, we can again come back to our earlier scenario. So our 3 questions were whether the patient was a candidate for ECMO. Now, if you remember our case scenario, which went like this: 3-year-old boy, myocarditis, paraflu positive, on very high inotrope supports, MAP was low, not perfusing well, lactate was increasing, mixed venous saturation was decreasing, the patient was becoming oligoanuric. So now we know about the indications of ECMO, VA ECMO. So would you think that the patient is a candidate for ECMO? I would say yes. If yes, what kind of ECMO? The patient has got cardiac failure, so definitely VA. And now is the question where to cannulate. We have already listen to the cannulation talks. It would be a cakewalk answer for you. So we know now that it's very important to choose the cannula of appropriate size, and we also know that resistance to blood flow through the cannula is directly proportional to the length and inversely proportional to the 4th power of radius. So with that in mind, we want to select the shortest and broadest cannula that is appropriate for the vessel size. And also Dr. Ravi told you about the heparin bolus that we typically give just before cannulation of around 50 to 100 units per kilo. So this is a chart that we used to use while I was working in sick kids. So when we are having this hands-on session, I will carry this pocket card. It's quite useful. There are several references, as Dr. Ravi had also shown, but you can probably take a picture of this, and you can probably keep it in your back pocket. I'll make it a point that I'll carry this. Okay. And then we also need to know what are the routes of cannulation. So for VA ECMO, typically in post cardiotomy scenarios where you have just come off cardiopulmonary bypass, you are unable to come off cardiopulmonary bypass, you have just finished the cardiac surgery, or even in ICU, the patient is gradually going into a low cardiac output state after a cardiac surgery, typically our cannulation would be central cannulation, which means you open up the sternum, you do a sternotomy, open up the chest, and then you cannulate directly into the right atrium, you cannulate directly into your aorta, right? So you can see in the picture, this is your aortic cannula, which goes into the aortic arch. This is your right atrial cannula, okay? And then there is a left atrial vent. This is something which I will talk about a little bit in the subsequent slides. And then we can also use peripheral cannulation. So for peripheral cannulation in children, we typically would be using our carotid artery for arterial cannulation, and the IVC for our, the IJV for our venous cannulation. And we can use the femoral artery, but typically the femoral artery is difficult to access in children less than 15 kilos, and best results we achieve in children more than 30 kilos. And whenever we are using femoral artery for cannulation, as was shown in the cannulation lecture, we have to monitor the limb for limb ischemia, and we have to strongly consider inserting a deperfusion cannula distally. And venous cannulation in the right internal jugular vein or the femoral vein, as I had mentioned, right? So now that we know the roots of ECMO cannulation in this patient who is kind of not post-cardiotomy patient, so we know the patient is a candidate for ECMO. We know that we want to put the patient on VA ECMO. So where to cannulate? So we want to cannulate peripherally. Remember, the patient's weight was 12 kilo. So I would suggest putting your arterial cannula into the carotid artery and putting your venous cannula into the IJ. Now that we have cannulated the patient and connected the patient to the ECMO circuit, then how much ECMO flows would you initiate? What would be your ventilator settings? And what is your thought on inotropes? Remember, the patient was on very high inotrope support initially. So, like again, how much flow is enough? That really depends on your perfusion. So you need to monitor the patient clinically. You need to monitor your urine output. You need to monitor your lactates, your mixed venous. If you have the facility to monitor NIRS, you monitor that. Usually, a rough guide is we generally start in children with a flow of around 80 to 100 ml per kilo per minute. That is a baseline. Some of the shunt lesions, like BP shunt patients, some of the high oxygen consumption states like sepsis, neonates, they would typically require higher flows like around 120 to 150 ml per kilo per minute. And then we titrate depending on, as I said, the perfusion of the patient, whether the lactate is clearing, whether we have evidence of good end organ perfusion, whether your urea creatinine, which was very high, that is coming down, whether the patient is generating good urine output. All right. So what we target is having an arterial oxygen saturation of more than 90% and mixed venous saturation of around 70 to 80% on VA ECMO, along with evidence of good tissue perfusion. What should be your target arterial blood pressure? We usually target mean arterial blood pressure, which is kind of age appropriate. Having said that, we will deal with this in kind of the hands-on session. ECMO is a laminar flow. It does not usually generate a pulsatile flow unless the patient's heart is contracting well. So the blood pressure might be usually lower, but we usually target MAP, which is kind of the mean arterial pressure, which is kind of age appropriate. So typically in this scenario, which was a 3-year-old child, I would probably target at least a MAP of a 45 to 50, given our the evidence of end organ perfusions are all good. Now, how much sweep gas, how much fresh gas flow should we start with? Again, this was something which came up in the chat box. Typically, we start with a ratio of gas flow is to blood at 0.5 is to 1. And we start with the FiO2 usually low in case of cardiac ECMO because their lungs usually are okay. And then we can titrate your gas flow and the blood flow depending on your carbon dioxide, and you can increase your FiO2 depending upon your oxygenation. Okay, and once you have achieved your desired flows, then you optimize your ventilator settings. Again, how much ventilator settings? As Dr. Krishna was telling in his presentation, we typically would be wanting rest settings because the goal is to provide rest to the lungs, rest to the end organs, and not cause any further damage. But having said that, it depends from unit to unit and what kind of physiology you are dealing with, right? Typically, let's say example, you are dealing with a patient who has undergone a cardiac surgery. The lungs generally would be okay in those patients. So if the patient has been cannulated just because the heart was not functioning very well, I would not mind having a relatively like normal kind of ventilator settings. But along with this, if the patient was having a bad lungs, let's say for example in this scenario where this patient had a myocarditis and the lungs were quite fluid overloaded, the lungs look white with high ventilator settings, I would rather want the lungs to have some rest. Along with that, I would also want to remain well recruited. So I would use PEEP of around 8 to 10, low ventilatory rates, and tidal volume of around 4 to 6 ml per kilo. Okay. And then your patient has been cannulated to ECMO. So we cannot manage the patient and the machine in isolation. We have to think about them in conjunction. So while we are looking at the ECMO circuit, we always have to give importance to the patient, right? So fluids and nutritions, I cannot overemphasize. Ma'am was also saying, like, if appropriate, if your like if your gut is functioning well, you start to feed them early, and that is how you prevent bacterial translocation. Sedation and analgesia, this concept of minimizing the sedation and a kind of awake ECMO is very valid nowadays in adults, but typically in children we usually try to keep them comfortable, not necessarily paralyze them always, but kind of sedate them and analgesize them so that they're comfortable, not moving a lot, so that we can maintain the safety of the cannula. And this more so applies for central cannulation, where the cannula positions are very, very important. Antibiotics, it depends on your clinical context. If you are dealing with a post-surgical patient, then typically they are probably not affected. So you can give antibiotic for a couple of days, 3 days. If there is no evidence of infection, you can come off antibiotics. But in patients who have been ARDS lung, also in this patient who was having paraflu positive, might have superadded bacterial infection, you probably need to give them some antibiotics and also do your other tests to rule out that the patient is not septic. You want to keep the lungs well recruited, so we do bronchoscopy. And when you think that the patient is suitable, the patient is gradually healing, then you try to come off ECMO and ultimately decannulate. And very, very important is post-ECMO care, because when you are on ECMO, you lose a lot of muscle strength, you have myopathy, you have neuropathy. So post-ECMO rehabilitation is probably as important as managing your ECMO circuit, as managing a patient while on ECMO. So now we have achieved our respiratory goals and hemodynamic goals. Our blood pressure is okay while on ECMO. We have dialed down our ventilator settings. Our blood flow is maintained at a particular rate. So we also have to anticoagulate the circuit, because your ECMO circuit is like very unnatural, right? Because you're taking out blood, moving it across a circuit, moving it across a lung, giving back to the patient. So your entire blood volume is outside the patient. So it's very unnatural. So you have to keep some level of anticoagulation. So usually we anticoagulate in our unit with heparin, although lately we have started to anticoagulate with bivalirudin. But for the sake of this presentation, I would say heparin, and we usually titrate heparin with our ACTs of 180 to 220 is what is our general target, unless the patient is bleeding. Platelets, what we target is at least more than 50,000. Some centers target platelets of 80,000. I used to work in a center before where we used to have a higher platelet target, but in our center at Narayana, we target a platelet count of 50,000 and above. And your hematocrit around 30 to 35. So that would mean a hemoglobin level of around 10. All right. So the other things that you monitor in the machine would be your pre-pump pressure, your pre and post oxygenator pressure, in order to determine whether there has been a pressure drop across the oxygenator, which is very, very important, which we will talk about further during the hands-on session. In the patient, we monitor our mean arterial pressure. We monitor the vital parameters like the heart rate, the temperature, the respiratory rate, and we monitor the other biochemical parameters like your lactate, your mixed venous. You should monitor the neurological status, especially important in infants and in neonates. And in our unit, the protocol is, if a cardiac neonate has been cannulated to ECMO, we do ultrasound every alternate day, head ultrasound every alternate day. All right. And it's also important to assess the wakefulness, and intermittently, although you are sedating them intermittently, it's important to come down on your sedation or stop the sedation momentarily to assess the wakefulness of the child. All right. Because it might have so happened that you might not have realized the patient might have a big bleed in the brain, and then there's probably no point in continuing with the support. So we had cannulated this patient, as I had said, by peripheral cannulation, and you can see that this was your arterial cannula, all right, into the common carotid. This was your venous cannula through the IJ into the RA, and then this was the initial X-ray, and then a day into ECMO run, you can see that the lungs come white out. So what has happened? What do you think has happened? So this is a typical thing which can happen with very, very bad heart, and you have cannulated patient on the ECMO. So what happens is you are giving blood at a very high rate into the aorta, right? Which produces a lot of afterload to the already damaged myocardium, which is struggling to function. All right. But there will be always some blood coming into the left side of the heart. Where is that blood coming from? It will be coming from your bronchial vessels. It will be coming back from your coronary sinus. So heart still has to pump out that blood. But because now the afterload is high because of the ECMO flow, the heart cannot pump out blood. So what happens is that blood accumulates in your left side of the heart. That kind of causes a back pressure, produces left atrial hypertension, produces pulmonary venous hypertension, and can lead to pulmonary hemorrhage and edema. So if that X-ray happens, then your patient probably is doomed. So you kind of need to anticipate which patients can have this left atrial hypertension after putting on to ECMO. And also what can happen is because your left ventricular end diastolic pressure is increasing in that way, it can compromise your coronary perfusion pressure, because the formula for coronary perfusion pressure will be your diastolic blood pressure minus your left ventricular end diastolic pressure. Okay. So what is your intervention? Anticipation is the key. So in this patient, if I had to cannulate the patient on ECMO, 25% or 20% ejection fraction, I will always tell my cardiac surgeon, please do something to check out blood from that left side of the heart. And what does that mean? That means venting the left side of the heart. That is called LA venting, or venting the left side of the heart. You can also, if there is expertise among your cardiologists, you can ask them to do a bled atrial septostomy. In our unit, we typically do a small thoracotomy and insert LA vent through the right pulmonary superior vein. So that exactly what was done. The LA was vented to the right superior pulmonary vein. Also, because the patient was anemic, we initiated CRRT. Over the next 7 days, the chest X-ray improving, and the child was intermittently waking up appropriately. So we thought that this is probably the right time that we should start weaning the ECMO flows. All right. So as Krishna said, one of the ways of weaning VV ECMO is just that you turn your sweep gas off and you are completely off ECMO. But it's a bit more complicated in VA ECMO. And what is important to do whenever you are going on to ECMO, you start your assessment from that point of time. You start your assessment, whether you ask yourself this question every day, whether my patient is starting to improve, whether I am ready to come off. All right. So one of the first things that you see on your while the patient is recovering is the improvement of pulsatility on your arterial line trace. So what do I mean by that? I had mentioned to you that ECMO provides laminar blood flow, right? So ECMO is not a pulsatile blood flow circuit. So when your heart is not working properly, you are fully dependent on your ECMO to provide cardiac output, your arterial line will be kind of flattish. Now, when your heart starts to recover and starts to beat, one of the first signs that you will see is return of pulsatility on your arterial line trace. So that tells you, yes, my patient is starting to improve. So probably I can think about weaning the ECMO flows in the next few days. All right. And when you are coming down on your ECMO flows, also you do an echo to assess the function of the heart. When you're on full ECMO flows, there is no point in doing echo. It does not add too much value, because then your heart is empty. You don't have good loading conditions. So when you actually load the heart by coming down on the decreasing the ECMO flows, then is the utility of doing an echo. How much ECMO flows to come down to, we can discuss in the hands-on session. And when you have weaned down your ECMO flows, it is also imperative to do your trial offs, which will be dealt with in the weaning session. And so when you think that your patient is ready, then what you do is you have your inotropes ready. You had some of your inotropes probably while you are on ECMO. Now again, increase your inotropes. You have your vasoactives ready. You have your emergency medications ready. You have blood products. You have volume. You have echo at the bedside. You kind of, in order to reduce your myocardial oxygen demand, you sedate and paralyze the patient. You go up on your ventilator settings. So that is a very important thing to do, because you had come down on your ventilator settings. Now we are trying to wean the patient on ECMO. You go up on your ventilator settings, okay? And then you gradually decannulate, okay? So specific complications, last few slides, specific complications of VA ECMO, distal limb ischemia, again, something which has already been taught. If you are cannulating the femoral artery, always anticipate that there can be distal limb perfusion issues. So you need to insert a distal limb perfusion cannula, all right, and then connect to your arterial side, okay. And you can have stroke, you can have bleeding. Cardiac thrombosis, as I had mentioned, if the blood builds up in the left side of the heart, you can have cardiac thrombosis, you can have coronary hypoxia, as I just mentioned. And the north-south syndrome, which Dr. Ravi had briefly mentioned, this is very typical of VA ECMO, and this happens typically in femoral cannulation. So what happens is the upper part of the body is blue and the lower part of the body is red. And why is that? You can probably appreciate from this picture. So what happens is you have probably cannulated a patient, say for example, this patient only, who was having a very bad heart, and at the same time, the lungs was very congested, the lungs was diffusely white. So you cannulated the patient on ECMO, let's say after a couple of days, and usually remember this, that heart takes lesser time to recover compared to the lungs. So let's say after 2 days, the heart starts to recover a bit. All right, and you had let's say, just for the sake of discussion, you had cannulated the patient through femoral loop. All right, so after a couple of days, your heart started to recover, so it started to pump out blood. Okay, so what happens is the heart starts to pump out blood, but now where is that blood coming from? That blood is coming from the lungs, but the lungs are not the lungs are quite bad yet. So heart is actually pumping blue blood, and the lower part of the body, which is actually being supplied by the femoral cannula, femoral arterial cannula, that is all oxygenated blood. So there will be a point where the blue blood from above and the red blood from below by the femoral arterial cannula, they meet. All right. So this is very typical of north-south syndrome, also called Harlequin syndrome, with where your lungs is yet to heal, but your heart has recovered. The upper part of the body is blue, the lower part of the body is red. All right. So what is the intervention that you do? You can increase your ECMO flow. There is no cardiac stunning. You can switch to VV ECMO if your heart has recovered, but your lungs are yet to recover. You can consider other recruitment maneuvers. You can consider putting the child on high frequency oscillatory ventilation. And as Dr. Ravi was mentioning, you can probably insert a jugular line. All right. So that's all I had to say. But then ECMO, the overall technology, as well as VA ECMO, if you select your patients appropriately, if you identify the indication appropriately, if you do your cannulation right, and if you monitor the ECMO, as well as monitor the patient well, and be cognizant about when to wean the patient, how to wean the patient, then you can really have fruitful result. All right. And I'll see you all during the hands-on session. Looking forward. Thank you.
Thank you, Shubhadeep. Thank you so much. So you can see VA ECMO is a lot more challenging than VV ECMO. VV ECMO is a lot more simple. So recirculation, hypertension are a problem with VV ECMO. VA ECMO, as Dr. Shubhadeep mentioned, you have, when the heart is bad, you have LA distension. When the heart is good and it is a femoral artery cannulation, with the lungs bad, still bad, then you have problem with Harlequin. Any question? There are some questions in the chat box.
Yeah, Krishna has answered a few. So one
Yeah.
of the questions, ma'am, which I can see, high drop in CO2. Is there a minimum target of hemoglobin? I thought I mentioned about that. So typically in our unit, we target 30 to 35 of hematocrit. And that's kind of typical target in most of the units. But like if the patient is perfusing well, if your end organ, if you're having good urine output, if your mixed venous is okay, then probably 8 to 10 of hemoglobin is also okay. All right. But then when you contemplate weaning the patient of ECMO, then it's probably appropriate to if your hematocrit is slightly low, it's probably appropriate to give some PRBC and get your hemoglobin up, because that kind of increases your oxygen carrying capacity. All right. So please explain the sweep gas settings on ECMO. Oh, that was done. Does descending out be the ideal site if you want to give complete rest to the recover in VA ECMO? So again, it depends on the scenario, whether you want to cannulate your descending aorta. So typically we directly cannulate the aorta in post cardiotomy patients, right? In other patients, we would be using peripheral cannulation. So there was this scenario, very odd scenario which we faced in the last week only. There was an adult patient, 25-year-old, ARDS, multiple organ dysfunction, and we were putting the patient on VA ECMO. Unfortunately, this was something which I had never faced before. So in our unit, what we do is we kind of do a hybrid technique. So I would do a percutaneous access for the surgeons, and then the surgeons, they would kind of dilate and then do a little bit of dissection and then cannulate. So here, unfortunately, we could not cannulate the femoral vessels at all, because I would give them access, but they could not dilate. Somehow there was some anatomical problems on both the sides. So this patient, although was not a cardiotomy patient, we actually opened up and then did a direct central cannulation. So descending aorta, you would probably have only access while you are putting the patient on central cannulation. Otherwise, even in very bad heart also, we would use peripheral cannulation. Peripheral, like carotid artery or femoral artery is just fine. And if you choose your cannula right, then you should be able to give enough rest to the lung, because it would generate enough flows.
Yeah. How to titrate inotrope dose on ECMO?
Again, it depends. Like if you are on full flows, you should not be needing a lot of inotropes, right? But sometimes it depends on the scenario. Like you might be generating full flows, a lot of flows like 120, 150 ml. But say a patient is having sepsis, severe shock, distributive shock. So still the patient may be hypotensive. So in those scenarios, you might want to use a pressor in order to have good perfusion pressure to the organs, right? In some of the scenarios, that say for example the scenario I just talked about, I would probably, if the map is okay, I would probably start to introduce some milrinone, some levosimendan, in order to it would act as an inodilator and kind of probably help the heart to recover. So that is another thing. But typically in this scenario, it should not be probably needing a lot of adrenaline and noradrenaline while the patient is on it.
So if there is vasoplegia, you add some pressor. But if the heart is bad and you are on good VA ECMO flows, you need good afterload reduction so that the heart is able to eject forward against the ECMO flows. So good milrinone, levosimendan, or whatever for good. So remember, the centrifugal pump on ECMO is preload dependent and afterload, preload sensitive and afterload dependent. So if there is an afterload, if the pump will not be able to generate good flows for the same RPM. The RPMs will continue, but your flows will drop down if your blood pressures are too high. So in a VA ECMO, you like to keep the blood pressures a little low, so it doesn't cause cardiac stunning, and it also improves the blood flow for the same RPMs. We will show all that in the workshop. There is one good question, Subhadeep. Possible reason for whiteout of lungs, which that can occur with any ECMO, I think, after VV ECMO, which were not completely white out before starting ECMO.
Yeah, I think Krishna is probably typing. Krishna, do you
want
me to answer or?
So ECMO is basically like a bypass. There's a lot of capillary leaks, sirs.
Yeah, so Krishna has already answered this. I can see.
Yeah, he's doing 1, 2, 3 already. So fluid overload, all the blood products that you have given, worsening of neutrally because of platelets and all that you give before your cannulation, sirs. So I think multiple reasons for why the lungs get worse before they actually get better. So the first 48 hours, they're worse. The patient has profound capillary leak, fluid overload state. Okay. So we want to wind up by 9:30 max before the Zoom link will close. So over to you, Dr. Kalyan. You can start sharing. Thank you so much, Shubhadeep. Yeah.
Thank you, ma'am.
So it is my pleasure to invite Dr. Kalyan. Dr. Kalyan was with us at Apollo Children's before he moved to Great Ormond Street. And now he is the consultant at Kim's Cuddles, Hyderabad. Over to you, Kalyan.
Thank you, ma'am. Thank you for inviting me as a part of this ECMO workshop. Am I audible, ma'am?
Yes, you are. There is some disturbance. Kalyan, there's some disturbance.
Your voice is breaking.
Your voice is breaking. Try again.
Is it okay now, ma'am?
Now perfect, perfect.
Right. So my screen I have shared. Are you able to see it?
Yes, yes.
Right. So my outline is going through introduction and what happens on mechanical ventilation. How does it change on while we are on ECMO? And I would rush through what is ultra lung protective strategies and how can we cut down the mechanical power. Adjuncts of respiratory measures like proning, bronchoscopy, physiotherapy, and how they are important. And few scenarios on VA ECMO where we need to little bit titrate our rest lung settings. And Dr. Subhadeep have already told like what are the scenarios where you would change your ventilation strategies on VA ECMO. So mechanical ventilation by far plays a major role in supporting most of the ARDS cases and cardiac failure in optimizing oxygenation, ventilation, and also hemodynamics. But however, especially in very severe ARDS, mechanical ventilation have deleterious effects. So one way to say is like both mechanical ventilation and ECMO are like brothers. And when there is a very much disturbance in the home, at severe ARDS where mechanical ventilation is creating much more complexities, ECMO might pitch in and reduce that complexity to certain extent. But the good interaction between ECMO and mechanical ventilation may reduce the amount of time that the child might stay in the hospital. So what are the principles of ECMO? Why we are putting ECMO for a very bad lung? It is whenever we are failing to ventilate a child on the safe zone, and within those sort of a pressure limits, if we are unable to ventilate, then comes the role of ECMO. And so basically to prevent barotrauma, prevent the biotrauma, prevent the myotrauma by keeping the child paralyzed for a long time, preventing the volutrauma and preventing the atelectotrauma. So all these things we are doing and providing the ECLS to majorly minimize the bleeding. So what does ECMO gives? ECMO gives an opportunity to reduce the tidal volume when you are not on at your target P flat. It helps to reduce your respiratory rate because it is going to take away the component of hypercapnia. You can reduce the FiO2, so you are reducing the biotrauma, and the entire blood is being bypassed through an oxygenator. And we can also reduce the PEEP, which can cause over distension in a baby lung. So ECMO per se is a sort of a modality to bypass the ventilator or bypass the ventilator-induced lung injury. So coming to the baby lung concept, it holds good across all the patients who have very bad lungs on prior to the ECMO, as well as soon after initiation of ECMO. Most of the kids do have worsening of compliance, even in cardiac ECMOs, in the first 48 hours because of multiple things that we have discussed. Here is Professor Gattinoni, whom we sadly lost recently. He is the one who have shown the way of how to ventilate severe ARDS, and he is the one who has created the initial papers on ventilating even on ECMO. So baby lung concept is here is a CT film where among the entire lung, there is a part of a non-recruitable lung called a consolidation, and there is a very small part of a lung which can actually take the air, that is a normal lung, and in between there is a part of a lung which may be recruited. More severe the disease, the smaller is the baby lung and lower is the volume that we could give. And by keep on ventilating and just praying that the middle zone to recruit is like harming. So the call of going on to ECMO should not be very much delayed. And earlier the initiation, whenever the child fits for the indications of VV ECMO, as discussed by Dr. Krishna prior, is the key for success of ECMO outcomes. How exactly to protect the lung on VV ECMO? So there are a lot of variables on the ventilator panel what we can do to reduce. So of which one sort of a recent one of our understanding is higher the power that is utilized during the child's ventilation is correlating to the outcome. So the power formula is like respiratory rate, elastance, PEEP, those things. So roughly it says like do low tidal volume ventilation, limit the PEEP plateau to 24, limit the rates, and avoid ventilator induced diaphragm dysfunction as much as possible. So that is like ultra lung protective ventilation, where you come down your set of the teaching of 6 ml per kg, and you titrate it down to the wherever the best safe ventilation that you could do, so that you're not going beyond your safe P plats of 24, 25, and accept even if you get like 2 or 3 ml per kilo of tidal volumes, and deal the rest of the things as much as with the ECMO. So that is ultra lung protective strategy. I'll go through each of the variables that we can set on the ventilator. So first is the tidal volume. We know this trial ARDSNet, where 6 ml per kg versus 12 ml per kg have shown clear-cut mortality difference in low tidal volume ventilation group. So this made people to think like, what if we reduce further by reducing the mechanical the strain given by the ventilator. So this is one of the rat lung where they have induced ARDS by giving acid, and they have checked the endothelial injury at different levels of ventilation. So at 3 ml per kg, the alveolar structure is not much changed, and at 6 ml per kg with PEEP of 10, there is some myofibroblasts that are going in, and at 12 ml per kg with PEEP of 5, there is a lot of alveolar edema and seepage of inflammatory mediators, and at 12 ml per kg with PEEP of 10, it is much worse. So ECMO enables a larger tidal volume reduction by taking care of ventilation, and we can reduce the tidal volume as less as 4 ml per kg. This is one of the trial called extra vent trial, where in severe ARDS they have changed their approach by randomizing into two arms. One arm with 3 ml per kg tidal volume, and give high PEEP as per ARDSNet, and deal with PCO2s by doing extracorporeal CO2 removal. And on the other limb, give 6 ml per kg tidal volume, and same high PEEP strategy as per ARDSNet. If you see the ventilator free days and ventilator at 28 and 60 days is showing a positive outcome for kids, for patients who have gone ventilation with a ultra low volume strategy. However, not much of hospital mortality have been seen in this trial, but it gives that rather than pushing the lung, probably ventilating safe is much more what it is required for a better outcomes. So what would be the ideal tidal volume? It is still debatable, but aim for a low tidal volume to limit the P-plats to less than 24. Also recommends targeting the tidal volume lower to prevent the volume trauma. So next, coming to the plateau pressures. Plateau pressures are very much easily measured bedside, and it is a very well-versed variable after ARMA trial. And here is a REVA research network, which is UK-based, Europe-based, and they have checked like in patients on ECMO post H1N1, they have seen pre-ECMO and as well as a post-ECMO. In the pre-ECMO, the non-survivors have the higher P-plats, which is more than 25. And at the same time, what is the reduction of P-plats after the initiation of ECMO? The reduction of P-plats on the survivor group is much higher compared to the non-survivors. So probably it gives more insight of how advantageous the ventilation, how advantageous the ECMO, and how important for us to bring down those P-plats and get the work done from ECMO to give a good lung rest. So next, coming to the driving pressures. Driving pressures are just surrogates of the cyclical strain with each breath that we give. So here are the two alveoli. One patient we are ventilating with a low PEEP and high delta P, which is the driving pressures. The other one is a high PEEP and a lower delta P, and capping the plateau pressure at a 25. And Amato have shown that as long as the delta P is coming down in the extreme right arm, the mortality risk is also coming down. And as long as the delta P is maintained the same and as safe, less than 14, the mortality is almost static. But if the delta P is maintained higher with low recruitment, keeping the PEEP static, the mortality goes up. So this holds good even on ECMO. This is one of the pooled data where it has shown among the ventilatory parameters, the driving pressure is a whole and sole independent predictor of mortality on VV ECMO. The other factors being age and organ dysfunctions as a mortality predictors. So the recommendation is keep the driving pressures less than 15 on VV ECMO ARDS group. So next, coming to the respiratory rate, cyclical lung collapse and expansion leads to biotrauma, and this also leads to increase in inflammation. So a reduced ventilator-induced lung injury have seen with the lower respiratory rates compared to the standard respiratory rates what we do in our usual ventilation. So, but we at the same time, the difference between keeping like completely apneic versus keeping some amount of respiratory rate. Some amount of respiratory rate might help you to prevent de-recruitment and atelectasis when we are already ventilating at ultra lung protection, like very low tidal volumes of 2 to 3 ml per kg. So for children, the respiratory rates of 10 to 20 can be selected depending on the age and size. In adults, somewhere between 5 to 10 of rates are being practiced currently. So next is mechanical power. It is by Gattinoni et al. Who have shown the mechanical ventilation to be an independently associated with mortality of when it is more than 17 joules per minute. And on Eolia trial, the mechanical ventilator is computed to be reduced to as low as 6.6 when initiated on ECMO. But at this point, we don't have much of a literature on how much mechanical power needs to be reduced to say that the lungs are at rest or lungs are not being hammered to cause ventilator-induced lung injury. So next, coming to the concept of just cut down all the rates, leave the child on some PEEP. So near apneic ventilation in animal trials in pig models have reduced the lung injury and and reduce the fibroproliferation, which is a way of predicting how soon the child might come out of VV ECMO. So sham is one pig model where they haven't done any damage, and in rest of the things they have done a lot of saline washes to create an ARDS. So sham is a pretty much healthy alveoli. Non-protective ventilation, where they are ventilating around 10 ml per kg of tidal volumes with higher PEEPs. So have seen a lot of inflammation. And conventional protective, the inflammation is lesser than the non-protective, but the fibroblast proliferation is seen at the alveolar edges. And in near apneic, it has shown to have least amount of inflammation in this model. But taking it into the bedside, total lung rest, like with complete apnea, can be tried in pneumothorax, difficult or recurrent pneumothorax on ECMO. But it comes to with a cost of we might increase the ECMO flows to keep up that minimal amount of CO2 that is becoming an issue, and which might lead to hemolysis. And there is a risk of atelectasis and need of much more higher pressures when we are recruiting. So next is a PEEP. The most important thing which we tend not to meddle quite a lot, because we still want to keep the lung open and prevent atelectasis. But there is no magic number. So no magic number when we are actually not on ECMO, pre-ECMO. The same ways, there is no magic number even on ECMO. Most of, in an international survey, most clinicians use a PEEP of less than or equal to 10. Also suggests a modest PEEP of 10. And the recent trial like lung rest trial and Eolia, they have used a higher PEEP for 10 to 15. So however, whatever be the number that we check, the PEEP need to be titrated to the underlying disease, hemodynamics, and recruitability, rather than just keeping and leaving it on a set guideline. So how exactly we can select a PEEP? By a titration, which at times is very difficult when the lung is stiff. But as we progress on the disease, we can keep titrating and check where exactly we are getting a better compliance, keeping the driving pressure static. By using the transpulmonary pressures, lot of trials by Schmidt et al. Have shown a bit of a benefit on ventilating with continuous transpulmonary pressure based ventilation. Electrical impedance tomography, a lot of French trials are going on. CT, not very feasible. Exposure to radiation, exposure to a lot of infection as we move out of the hospital, just to select the PEEP. Lung USG, very much used model to select a PEEP and how we are ventilating, and recruitment to inflation ratio by using the ventilation models. So among these on ECLS, transpulmonary pressure guided, we have a large data. It is a bedside tool. It is radiation free. But main problem is having the probes in our unit, having such a ventilator in our unit, which at present is quite limited. And even at the centers where we have, because of the cost issues and the availability of the probe issues, it is always a challenge to have it on all the ECMO kids. But the risk of frequent dislodgement, and at the same time, it is influenced by various artifacts. Then coming to the CT guided, we have shown it is cumbersome and not very much in clinical practice. Next is electrical impedance tomography, where we can do a cross-sectional evaluation, and we can check how much of the lung is actually getting recruited by a dynamic assessment. But it is a small sort of a band that is across the chest, and it can give only cross-sectional. It can't give what is there in the apex, what is there in the base. So we can just get a cross-sectional data. So this is one of the trial from Wang, where they have seen that a proportion of patients who got successfully weaned are higher on the group which are ventilated with transpulmonary pressure guided strategy. So that was one of the ventilator where we were using the transpulmonary pressures. The aim is to keep the PTP always being on the positive side. Next is going to the sedation and paralysis. So with accuracy trial have shown a lot of advantages while we are on paralysis in the first 24 to 48 hours. But the recent trials have not validated the previous data. So now in the first 24 to 48 hours, where we are still balancing the ECMO flows, hemodynamics and all, it is recommended to have moderate to high sedation plus or minus paralysis, and always keep the sedation with a validated score, because while on ECMO, the ECMO circuit takes a lot of sedation. So a lot of sedation what you are giving is being eaten by the circuit. So having a validated score and being sedation and titrating the sedation to that score is much more needed to either not too low or not too high sedation, and it should be tailored to the individual. And whenever we are weaning off any of the sedation, risk of patient-induced self-inflicted lung injury need to be adjusted, because it per se leads to a derecruitment, inflammation, and increase in lung volume and barotrauma. So next comes what are the variables that we monitor on ventilation. So periodic assessment of ventilation is needed. Two variables we see, like one is oxygenation, the other is a ventilation. Through the oxygenation, the routine classic ratios what we see are completely useless when we are on ECMO, because ECMO is taking care of most of those variables. One bedside thing what we could do from day 2, day 3 onwards is going up on FiO2 and check what's happening to the PaO2. So if the lung is contributing, there will be a good effect on PaO2. There will be a jump on PaO2 of the patient. But this trial should not be just keep we increase SS but come down to the FiO2 of a safe limit, because higher FiO2 leads to more biotrauma, and less than 50% FiO2 is advocated by also. So and if the lung is not going to do is not contributing much, there will be hardly any change in the PaO2 when you have given a change of FiO2. Coming to the ventilation, on the ventilation, what we can do is like a trend of EtCO2. Initial EtCO2s will be low because mechanical ventilation will be low. As compliance increases, you see a trend of EtCO2 that is going up on the monitor, that says that the lung contribution is going up, and we can also check the compliance on day-to-day basis. And also we can do the chest X-ray and focus. We need to evaluate right heart function on day-to-day basis. We need to rule out the effusions. We need to rule out hemo and pneumothorax every time, regular, and always when we get any flow related issues, rather than just going through giving the boluses, increasing the sedation, we should always check the right heart function on VV ECMOs. 2020, the ELSO guideline suggests limit PIP, limit FiO2, PEEP 5 to 15, titrate based on the disease, PaO2 66 to 90. This was the PaO2s that were set as per the EOLIA trial. but the PaO2s of 60s can also be tolerated as long as the lactates are maintaining and the child is being well. Sweep gas to aim for PCO2 40 to 45. An early drop of PCO2 from a very big number at the initiation of ECMO is a direct correlate for CNS events on ECMO. At the same time, persistent elevated PaO2s of on ECMO is also correlated to longer hospital stay and a longer stay in the hospital. So CPAP only and no pressure when there is a pneumothorax. Oxygenation and ventilation on ECLS should be titrated on the ECMO circuit first and should be dealt on ECMO circuit as much as needed, rather than going up on the ventilator and deviating our path away from the mechanical lung protection strategy. So these are some of the numbers that were used on different guidelines. The ELSO guideline says that the ELSO guideline says use pressure control, use modest sweep, relatively less delta P, and low respiratory rate to start with. And REVA, we have already gone through that sort of a trial where mainly the concentration is P plats of 20 to 25 and FiO2 of 30 to 50. Caesar, they have set the respiratory rates at 10 and peak pressures of 20 to 25. Eolia, they have set higher pressure at 20 and PEEP of more than 10. And in VA ECMO is more or less the guideline says that not to change much from the don't change your strategies much away from your VV ECMOs. So what are the adjuncts to improve your ventilation? So as I said before, touching the mechanical ventilator and doing a lot with the patient, just check what exactly you're doing with your circuit. Are you on a good enough flows? Are you having a lot of recirculation? Are you having a clots in the in your oxygenator? Is your oxygenator functioning well? And what is the sweep that you are giving? So I have gone through the previous questions where they are going through. They are asking about how exactly that you titrate the sweep. This is the right upper corner one is the sweep that we are seeing. So there are two knobs. The one knob is the FiO2 knob, which majorly influences your PaO2s. The two arrows which I'm showing are the knobs of the sweep gas flow. So the sweep gas flow on the right side is the liters, and on the left side it is on the lower volume, that is from 100 to 1000 mils, which more or less you dial up with respect to the flows. So when you initiate, don't go upon the flows like with the usual formulas of 1:1. Go slow with your sweep gas flows, especially when you are pre-initiation ECMO PCO2s are on the higher side. And the lower part, this sort of the blender gas goes onto this oxygenator port, where it is it would go as a sweep gas, and the lower ports are the heat exchangers, and across the oxygenators we have this sampling ports to take the pre and post oxygenator gases. So the other adjuncts after adjusting to your VV ECMOs are proning, addressing the fluid balance and collections, bronchoscopy, and physiotherapy. So coming to the proning. So proning is more or less like you're optimizing the shape matching, you're eliminating the gravity, you're eliminating the weight that is onto the posterior part of your lungs, which are most of the times involved in ARDS. So it is providing a better shape matching to recruit. So this is the ProSeva trial, which have shown the group have shown a all-cause mortality being low, and can we extend this onto the kids who are on VV ECMO. So it may benefit the recruitment, especially in the later phases of ECMO when the inflammation is lower. But the team comfortability and team feasibility logistics needs to be measured. And I always advise, like, do it when the team is full in the morning time, when you have more hands. Always calculate the risks of decannulation, bleeding, extubation. So get a chest X-ray prior to the proning as well, to secure the things and get the things corrected. And what does the trial say? The trials are at present, there are some conflicting controversial results, and we as a unit, we tend to do on VV ECMO patients. This is one of our VV ECMO patients whom we have done the VV ECMO for around 62 days. So we are here proning the child, keeping the child prone for 16 hours, and then keeping supine for 4 hours, and then proning the child back again. And yes, as I said, we need to have wonderful team. We always have our perfusionist whenever we are proning. We have like 2 fellows, 2 consultants, and 2 nurses always when we are proning, and always assess like whether this proning is going to help the child or not. And we need to have a checklist how good the proning has affected based on the X-rays, variables like compliance and the oxygenation, so that whether this trial needs to be done prolonged or not. So coming to the literature, this is one early retrospective single center
Kalyan, we
trial.
have another few more minutes only. 9:30.
Yes, ma'am. I have another 5 slides max. So prone positioning have shown to be shown to show a benefit, and this is one randomized control trial, larger one across multicentric, has not shown much of a benefit when you do a proning as a standard in all VV ECMO severe ARDS subgroup. Next is fluid balance and effusions. Fluid balance is shown to increase the odds of mortality, and appropriate deresuscitation measures needs to be taken. Always rule out hemo and pneumothorax whenever such a thing arises. So make a consensus and sit as an expert team rather than jumping to correct the smaller collections. Smaller collections, wait and watch. Hemodynamically significant collections need to be taken care with experienced hands to keep the surgeons always being involved. CRRT can be initiated aside of ECMO, especially in cardiac cases and in kids with MODS. It can be recruited either in ECMO circuit or with an individual HD catheter. So here we have kept an ICD on a child with recurrent pneumothorax with a blunt dissection. And we usually bring down our ACTs peri-procedure for at least 4 hours down to 150s as a institutional practice. And onto the right side is our MODS patient on VA ECMO, where we had to start on CRRT to deal with both cytokines as well as the fluid overload. Next is utilization of bronchoscopy. Flexible bronchoscopy being increasingly utilized in across the centers. It helps us to diagnose the airway anomalies, tube malpositions, ruling in and out of VAP, aids in lung toileting. Here is one of our kids like whom we had difficulty in ventilation on ECMO, and we have seen something like a finger-like projections, like a plastic bronchitis that is sitting onto the intermediate lobe of on the middle lobe of right side of the on the right intermediate bronchus, which we had to toilet by using the forceps. Post which we had a better oxygenation and ventilation. So so that was the finger-like projection, which is a thick plastic bronchitis, plastic bronchus, which we had to clear. So next is physiotherapy aims to facilitate the mucociliary clearance. It helps in re-recruitment and airway clearance. The techniques that were used, modified postural drainage, especially when you have single lung involvement, saline installation, expiratory vibrations, and ET suctioning. The adjuncts are direct saline lavage by using portable bronchoscopy and mucolytics like NAT, 3% hypernap, DNAs. DNAs we used to use for cystic fibrosis patients in UK when they are on ECMO. Surfactant lavage, much more seen in neonatal when they develop pulmonary hemorrhage with limited amount of research on it. And bronchoscopic assisted physiotherapy is much tried when we are having more issues with the CO2 rather than oxygenation. So INO can be used for RV dysfunction on VV ECMO. Pre-ECMO INO need not be continued because when we are on good flows of ECMO and it is doing well, a need of INO is almost a rare occasion, as long as the pulmonary hypertension is a reactive one. And establish the pulmonary hypertension like thick musculature across the pulmonary walls is anyway INO may or may not be working in those cases. So the most important adjunct for any of the ECMO cases is infection prevention, hand hygiene, infection control policies needs to be strict, head and elevation, oral hygiene using chlorhexidine, daily sedation assessment, prevention of DVT, and proton pump inhibitors, like the usual VAP bundle what we see. And at the same time, as soon as the daily assessment, just like in ventilation, we also need to make sure that how early we can come off of the ECMO is a sort of a bundle that we need to is the way to look forward. Soon, probably we see in a literature like VAP bundle, central line bundle, we see an ECMO bundle soon. So in VA ECMO, the scenarios, the strategies are same, but we need to be watchful that pulmonary issues might come which are not there pre-ECMO, like worsening of pulmonary edema, LV dilatation and dysfunction, which are going to raise the LAP, and the pulmonary edema from the back pressures, inflammation, and both inflammation as well as raised pulmonary edema, raised back pressures can lead to pulmonary hemorrhage. So this needs to be watchful, and critically low transpulmonary blood flow and very low low pulse pressures always makes us think that there might be some blood flow stagnation, and we might need to ventilate the child a bit better, and also give some afterload reduction so that the pulse pressure is better and we get some pulsatile flow back. So always the heart-lung interaction still holds good when even on ECMO of whatever we do. So higher PEEP may reduce the pulmonary edema, but higher PEEP can increase the vascular resistance. Higher PEEP reduces the LV preload and LV afterload. So PEEP might be helpful in VA ECMO kids, and higher PEEP helps in recruiting. And once recruited, the pulmonary vascular resistance might come down. So ventilate at around, try to keep it around FRC as long as your lungs allow. And if the lungs doesn't allow, stick to ultra lung protective ventilation. So ventilation needs to be adjusted when the myocardial function is recovering and we have differential hypoxemia, as in FEM cannulations, we see north-south syndrome, where the entire upper body, especially the carotids, are with hypoxemic blood, where you might need to recruit the lungs a bit more, change to HFOV, change to HFOV when needed if the lungs allow. Otherwise, we might need to change to a VA ECMO to VV ECMO. So the take-home messages: gentle ventilation, permissive hypoxemia and hypercapnia. In VV ECMO, anyway, it's a mixture, so accept the saturations at around 80. Regular monitoring and patience is the key. Don't expect on a very bad lung When you start on VV ECMO, the child would be decannulated on 5th day or 6th day. That happens only in chemical pneumonitis and poisonings. In a proper infective, especially the viral pneumonias, patience is the key, and during the patients, don't give any infection. Ancillary supports plays a major role in the ECMO success. Assess the bleeding and logistic issues before any procedures, and teamwork is the best work. So here, I want to say this, an all-out poisoning went up for a severe ARDS, where we had to start the baby on VA ECMO because the child is 9 kilos, femorals are not well developed. So we went on to VA ECMO flows at the referral hospital, started on ECMO. We transported the child on flight, did air ECMO transport, then changed to a road transport from the nearby airport and back onto our sort of arena or a den. So which came out to be successful, and got decannulated on day 8. And one more ECMO run we have just finished post turpentine injection, decannulated day before, and doing well on the wait for extubation tomorrow. Thank you.
Thank you, Kalan. Thank you so much. So see you all 9:30. Fantastic. And we're ending up with such a nice, happy story. So ECMO saves lives. So look forward to seeing you all tomorrow at 6 p.m. And feel free to interact. Go take rest. Okay, thank you. Thank you to all the faculty and the delegates here for the patient listening.
Thank you, ma'am.
Thank you, ma'am.
Thank you, everyone.
Thank you, ma'am. Good night.
Good night. Thank you, Krishna.